Bajaj sir as a president and Dr. Vijay Zawar as a treasurer and myself as secretary. And in last 10 years, we have done many educational activities. Typically, we see to it that we have got an international speaker to give us latest update on the thing. And our society Well, welcome all. Let me tell you, this is being streamed live to many dermatologists all over India, as we have got many prominent faculties on urticaria, atopic dermatitis, and contact dermatitis. So, as you told, Skin Allergy Society was formed in 2013 with A.K. Bajaj sir as our main founder president. We lost him during COVID time, but we'll remember him always for his all the support which he had given us. So what is it? It's a basically, we know that skin allergy is a prominent specialty. Typically in India, we don't have allergologist, but abroad there are allergologists who takes care of all the allergies. So the Skin Allergy Society, which area of operation all over India, was created by a group of enthusiastic and energetic dermatologists from all over India in 2013. Our aim is to encourage evidence-based ethical practice in the treatment of skin allergy disorders. We focus on atopic dermatitis, allergic contact dermatitis, angioedema, and urticaria. So more than 8 years in existence, more than 500 registered doctors and more than 40 events. That's a short story what we've done in last 8 years. Well, this is skinallergysociety.org website to give you updates about the events. Well, we are not only into holding meetings, we do publish, and our publications are being valued all over India and all over world. The few of the main publications what we had was the urticaria update in 2017, which is quoted and which has got many high citations all over world. Then the bilastine for treatment of chronic urticaria, a consent statement which we publish, which is also been quoted all over world. Crisaborole in the treatment of atopic dermatitis, this was another statement. Unfortunately, the molecule is not yet available in India. And we have got a SARS newsletter. And to add to all, we have got a Indian Journal of Skin Allergy, a dedicated journal of skin allergy, one of the unique journal where we try to publish latest articles on skin allergy. So do join us. There will be an important announcement about Indian Journal of Skin Allergy at the end of this program. So we have already issue 1 where there was a editorial and international article on inducible urticaria by EMEC. Issue 2 is already been published, urticaria and comorbidities. These are the articles by world authorities on urticaria. They are worthy of reading and it's free access online. So please go through it. And now we invite articles for next issue, that is number 3. So any of your articles you are welcome to send. Well, that's all for us. Thank you for the information about the Skin Allergy Society. Before we start our main program, I invite for a traditional lamp lighting ceremony our main international speaker, Dr. Luis Encina, and his wife. I request our secretary, Dr. Abhishek Day, treasurer, Dr. Nidhi Sharma, and our main founder and well-wisher, Dr. Murlidhar Rajgopalan, and again our guide and mentor, Dr. Sandeepan Dhar. So I request all of you to please come here for lamp lighting ceremony.
सूर्यक्षितेरिषः जीवनस्य गणाधिपः।
Namaskar, Adab, Sat Sri Akal to everyone seated today in the audience, and BM Viendo to Dr. Luis and his wife Dr. Anna. I hope you're all ready after a great breakfast on a bright sunny morning this Sunday on the 8th of October. I am Dr. Sahil Sethi, and I'll take you to the first session this morning, that is on urticaria. I'd like to begin by calling on our chairpersons for the morning's first session. First chairperson for the session is Dr. S.K. Bose. I'm sorry. Okay, he'll join afterwards, but our second chairperson for today is Dr. Rajendran S.S. He's a retired professor from Madurai Medical College, Madurai. He's a life member of IADVL. He's International Fellow of American Academy of Dermatology, International Member of the European Academy of Dermatology and Venereology. He's a Senior Consultant Dermatologist at the Vadamalayan Hospital in Madurai. Can we have a huge round of applause while we welcome sir on stage, please? So I'd like you to come up on stage and introduce our panelists and the moderator for today's morning session, sir. Thank you.
Thank you for the words of introduction. If you think of urticaria, it is difficult to forget the name of Professor late Dr. Malcolm Greaves, because it was he who imbibed me So it was Professor Dr. Malcolm Greaves who imbibed me an interest in this subject urticaria long back when I came across him at St. John's Institute of Dermatology, London, where he was running an exclusive clinic for urticaria, where patients from all over England, patients suffering from chronic urticaria used to come and see him. He is no more. He passed away last year, 2021, due to cardiac failure. So with this few words on urticaria, without wasting further time, I wish to introduce I am privileged and honored to introduce the international speaker for the day, Dr. Louis Philippe Ensina from Brazil. He is a research associate, Division of Allergy, Clinical Immunology and Rheumatology, Department of Pediatrics, Federal University of Sao Paulo. And he is also the scientific secretary for the Latin American Society of Allergy, Asthma and Immunology. And he is also the coordinator of the Department of Urticaria, Brazilian Association of Allergy, Asthma and Immunology. And he is the president of Brazilian Network for Urticaria, Rubra. So I invite Dr. Louis Philippe Ensina for his lectures. Thank you.
Yes, okay. Good morning, everyone. It's an honor to be here. Thank you for the invitation. We are enjoying very much our first visit here in India. Thank you all for coming, and for those who are attending online. It's also a great pleasure to share our experience in urticaria with you. We'll check the time to not pass the limit. Well, today I'm going to talk a little bit about the last version of the urticaria guidelines. No, it's not working. Okay. So these are my disclosures. I work in clinical research. I'm also a speaker of some pharma companies. Well, why it's important to know about urticaria diagnosis and treatment? Because 1 in each 5 person once in a life will present with some kind of urticaria, generally acute urticaria. When we go to chronic spontaneous urticaria, we see a different prevalence between different countries. In Brazil, we have 0.41% of prevalence, 0.1 in the United States, and here in Asia, 1.4. So it's a high number of patients with the disease. And the most important of it is that urticaria has a big impact in the patient's quality of life. As we can see in this figure, the impact of life on quality of life regarding urticaria is greater than other dermatological diseases like vitiligo, psoriasis, or hanseníasis. So it's very important to treat these patients in an adequate manner to give them back their quality of life. And to help us in this task, in diagnosing and treating the patient, we have these international guidelines, which the first one was back in 2008, if I'm not wrong, and the last one in 2020. So this is a real guideline. It's not just a group of experts that each one writes a part of the recommendations. This is really a consensus. Very briefly, the guidelines works in this way. We have a panel of experts representing different specialty societies around the world that choose 25 key questions that are going to be answered with a huge literature search, and where we are going to select the right papers according to the evidence quality. So we have these questions, we have the answers based on the literature, and these answers are going to be, these papers are going to be discussed, and some answers for each question are going to be proposed as a recommendation or a suggestion accordingly to the force of the evidence. And these questions and answers will be voted. So in one meeting, the last one was online, of course, but this is the 2016 meeting. All of this group of experts and everybody that would like to join the group is welcome. So for each question and each recommendation, each one that are attending the meeting will raise a green or red card. Green if he's considering the recommendation okay, or red if he or she doesn't agree with that recommendation. When we have more than 90% of consensus, then that recommendation or suggestion goes to the guidelines. So as you can see in the yellow dots, I don't think if you can see there, I'm right here and right in front of me, Dr. Kiran Godse. We have been participating in these guidelines for a while. So I'm going to separate the presentation in three parts of the guidelines. The first one, just some urticaria definitions. The second one, urticaria diagnosis, and the third, about urticaria treatment. So the definition that the guidelines gives us is that urticaria is a condition characterized by the development of wheals, angioedema, or both. The wheals, in Portuguese we say urticas. This should be translated, I don't know why, maybe at the time that I saved the file it didn't change, but a wheal has three typical features. It's a circumscribed superficial lesion with a central swelling of variable size and shape, and almost invariably surrounded by reflex erythema. The wheal always itch. Sometimes the patient may also complain about a burning sensation, and it has, and this is very important, this fleeting nature. Appear and disappear, returning to its normal appearance. In general, it lasts 30 minutes up to 24 hours. And the angioedema is characterized by a sudden, pronounced erythematous or skin-colored deep swelling in lower dermis and subcutis or mucous membranes, a sensation of tingling, burning, tightness rather than itch, and a resolution that can last up to 72 hours. The most common parts to be affected in angioedema are lips, tongue, and eyes. The guidelines propose this classification in acute or chronic urticaria, depending on the time that the disease lasts. So for chronic urticaria, we consider the patient that has symptoms every day or almost every day for more than 6 weeks. And chronic urticaria can be divided in two types, spontaneous or inducible. Inducible are those that we can reproduce whenever we want. So the secret for differentiate these two types of urticaria is asking the patient if he or she can induce their symptoms at that moment. If the patient says, yes, I can, so that's inducible urticaria. And we have many different triggers for this type of urticaria, like cold, heat, sunlight, water, and so on. The mast cell is the main cell involved in urticaria, in all types of urticaria. The mast cell is activated by different mechanisms and releases histamine, cytokines, prostaglandins, and leukotrienes, being the histamine the main mediator for the symptoms of urticaria. In acute urticaria, the triggers for the mast cell activation are generally virus, especially in children, food by an IgE mediated mechanism, drugs by IgE or non-IgE mediated mechanisms, but up to 50% of the patients with acute urticaria just don't have a specific trigger, and are some of these patients who will evolve to a chronic spontaneous urticaria. Chronic inducible urticaria, as I've shown you, can be triggered by cold water, sun, cholinergic when the body temperature increases, and spontaneous urticaria that in the past we used to say idiopathic urticaria. We don't use this nomenclature anymore. It's caused mainly by autoimmune mechanisms, a type 1 autoimmune mechanisms, That means IgE against autoantigens, against your self-proteins, or a type 2b autoimmune mechanism. That means IgG against IgE or IgG against IgE receptor on the surface of mast cell. Two ways of activating the mast cell in chronic spontaneous urticaria. So moving on to urticaria diagnosis. This is the algorithm for differential diagnosis. It's the same as in the last version of the guidelines, but it's very important. Here you can see that the patients may present just with wheals and angioedema, or just angioedema. Around 10% of the patients with chronic spontaneous urticaria will present just with angioedema. But when the patient presents just wheals, it's very important to ask them if they have recurrent and unexplained fever, joint or bone pain, malaise. Why it's important? Because those are signs of autoinflammatory diseases. Autoinflammatory diseases are rare, but they exist, so we must investigate. Another important point is to check the duration of the wheal. If the wheal lasts for more than 24 hours, we should do a biopsy of the lesion, because one of the differential diagnoses is urticaria vasculitis. So check the time that the wheals last, and if it's necessary, do a biopsy. For the patients that present wheals and angioedema, we just have to check if the wheals are inducible or not. Most of the time are not. But remember that the same patient can present both chronic spontaneous urticaria and chronic inducible urticaria at the same time. To diagnose the chronic inducible urticaria, we are going to see later, we do the provocation tests. And for the patients who present only with angioedema, please ask about the use of drugs like ACE inhibitors or anti-inflammatory drugs. Stop the drug, check remission. If this patient does not respond to antihistamine, corticosteroids, and it's a recurrent angioedema, consider the possibility of this patient having hereditary angioedema. It's also a rare disease affecting more than one person in the family in general, but it's very important because of the mortality. Hereditary angioedema is a disease that kills the patient. And the guidelines also stress the importance on defining what is not urticaria. So when we are facing a patient with urticarial lesions, how to differentiate what is urticaria or not? We saw the characteristics of a typical wheal, but there are also atypical wheals that are not urticaria. These are infiltrated plaques that are persistent for more than 24 hours, a symmetric distribution, and the resolution is with signs like hypo or hyperpigmentation or scarring. There are maybe other associated elemental lesions like papules, vesicles. These atypical wheals can itch, sometimes not, and they are usually not associated with angioedema. So this is new in this new version of the guideline, is the 7 C's of urticaria, just to remind us about what should be asked to the patient and what should we do when we are seeing a patient with suspected urticaria. So the first one is to confirm the diagnosis, rule out other differential diagnoses. The second C is for cause. Look for indicators of an autoimmune urticaria type 1 or type 2b. The third C is about cofactors. Try to identify potential triggers, aggravators, we must remember that chronic spontaneous urticaria may have some specific triggers like non-steroidal anti-inflammatory drugs. The fourth C is for comorbidities. Patients with urticaria frequently present comorbidities, especially anxiety, depression, and some others. There is a big study in the UCARE network being prepared to study these comorbidities. Then consequences, identify problems with sleep, distress, sexual health, work, social performance. Those are also important. Assess potential biomarkers, and this is very, very interesting. We already have some biomarkers to predict treatment response, for example, I'm going to show you later. And the last C, monitor CSU activity, impact, and control. We have some specific tools for that. These are these patients' reported outcomes tools to assess activity, quality of life, and disease control. For urticaria, we have some. For angioedema, we have others. Each one with a specific characteristic. When we are doing research, we should use all of them, but in clinical practice, my advice is to use the UCT, the Urticaria Control Test. It works both for urticaria and angioedema, and it's very simple, very easy to use, in opposite to the UAS7, which is the most known of these tools, which is a prospective tool, and sometimes the patient forgets to fill the form and they do it just right at the consultation. The UCT is a 4-question tool with 5 options of answers. I apologize for this version in Portuguese, but the patients do the test at the time of the consultation in front of you. And it's a retrospective tool, so it considered the last 4 weeks. And accordingly to the answers, we have a score that goes from 0 to 16, and we consider the disease control when this score is 12 or over. So this is very useful to use in our clinical practice, and we are going to see how can we use this with the treatment algorithm. Regarding investigation, that's another point. At least in Brazil, we see doctors asking for a lot of different blood tests for urticaria patients. In acute urticaria, we just don't have to ask for any lab test. Otherwise, the patient has a very clear history of urticaria related to some specific trigger, for example, shrimp. Like, I ate shrimp and 15 minutes later I had an urticaria, so we should investigate a shrimp allergy or any other food allergy. But otherwise, we just don't have to ask for lab tests. For chronic spontaneous urticaria, there is a minimum routine recommended tests that are differential blood count, ESR and or CRP, total IgE, and anti-TPO. Differential blood count to assess lymphoproliferative diseases, infections that could be associated with urticarial lesions. ESR or CRP to assess rheumatologic diseases that could present with urticaria. And this last two, total IgE and anti-TPO, was introduced in this version of the guidelines because they can be very useful. We are going to see in the next slides. If the patient has in his or her history other signs of or other symptoms that could or should be investigated, we can also do it. We can do diagnostic tests for infectious diseases, functional antibodies, even allergy, but we just have to take a lot of care regarding this. We are just going to investigate other diseases if there are some compatible history. In general, we don't investigate allergies in chronic urticaria patients because chronic urticaria is not an allergy. Maybe it could be an autoallergy, but not an allergy to some external protein or trigger. So it doesn't make sense to ask for skin tests or specific IgE to multiple antigens in blood for patients with chronic urticaria. So this is one of the interesting papers that came up in the last years. It's from the group of Romy Saini in Baltimore. In this paper, they described that patients with a total IgE above 15 have a greater chance to respond to omalizumab. So you do the total IgE test before prescribing omalizumab. If it's under 15, the chance of being a good responder to omalizumab is 50%. So if the IgE is under 15, we are not going to prescribe omalizumab. No, we are going to prescribe, but we know that the chance of response is not so good as a patient with a total IgE of more than 100, for example. The group from Turkey, from Hagi Pertas, they also described that when you dose the total IgE before and 1 month after the first dose of omalizumab, if the levels of IgE double, the chance of this patient having a good response for the drug is high. If the total IgE does not double after the first dose of omalizumab, probably this patient is not going to be a good responder. So it's interesting to use IgE to predict response to omalizumab. Of course, there is not a definite cutoff value. This should be studied in each different population, but just for us to start to think about using it and doing some research to define better which could be these cutoff values. IgG anti-TPO is also associated with autoimmune urticaria. We see that when the patient has positive IgE antibodies, positive basophil activation test, and positive autologous serum skin test, this patient is considered having a type 2 autoimmune urticaria, that is that one that I told you, which the mechanism involves IgG anti-IgE or IgG anti-IgE receptor. So when we have a high IgG anti-TPO and a low IgE, this patient is probably a patient with type 2 autoimmunity, and the chance of this patient to respond to omalizumab is low. Moving on to the chronic inducible urticaria diagnosis. For each type of chronic inducible urticaria, we have a specific diagnostic test. For example, for cold urticaria, we have the cold provocation and threshold test. For symptomatic dermographism, we can elicit the dermographism and threshold test as well, and so on. Just to give you an example, this is a 3-year-old boy with cold urticaria with a positive ice cube test, and also a patient with a solar urticaria. We exposed the patient to the sunlight in a limited area of her skin, and you can see the formation of a wheal in the place where the sunlight was, the patient was exposed to sunlight. Now, talking about urticaria treatment, let me just check my time. Okay, this is one of the quotes of the guidelines: treat the disease until it's gone. So we are not just going to start treating and after 1 or 2 months we stop the treatment. We have to treat the patient until the urticaria is gone. We know that urticaria chronic spontaneous urticaria at least, may last for 6 months to 5 years in general, but some patients can have CSU for 15, 20 years, and we should be treating them until the disease is gone. Here I show you some the evolution of the treatment algorithm guidelines from 2008 to 2016. You can see that in all of them, the first step of treatment are non-sedating antihistamines. The second step, updose these non-sedating antihistamines. And the third step is changing over the time. In 2008, we had montelukast. We could change the antihistamine. Then in 2012, we could add cyclosporine or omalizumab. In 2016, omalizumab was the third line and cyclosporine the fourth. And now in this 2020 version, it's a little bit different from the last one. We have just 3 steps. The first one, antihistamines in standard or high doses. It's important here to stress that we don't updose like 1, 2, 3, or 4 doses. We go from 1 to 2 and 2 to 4. If the patient does not respond in 2 to 4 weeks for that dose, we updose and we wait 2 to 4 weeks for each one of these updosing steps. We don't use more than 4-fold doses of antihistamines. If that's the question, if the patient does not respond to 4-fold doses, we move to, or we add omalizumab. So omalizumab is the second step. And now in this version of the guidelines, we can also increase the dose of omalizumab or shorten the interval. How long should we wait to see an omalizumab response? 3 to 6 months is enough, and we can use IgE levels to guide us to wait shorter or longer, 3 or 6 months. If a patient has a very low IgE, I personally would not wait for 6 months to check a response. And for those who do not respond to omalizumab, the third line of therapy is cyclosporine. We can use cyclosporine combined with omalizumab as well, as I'm going to show you. So why is important the UCT, as I told you? According to the control of the urticaria, if the urticaria is uncontrolled, we have to step up, increase antihistamines dose, or add omalizumab, or add cyclosporine. If the patient is well controlled, we continue the therapy, try to optimize, and wait for a complete control, which is UCT 16. When the patient is complete controlled for at least 6 months in my practice, I start to step down. Of course, we have to base this on individual factors, but after 3 to 6 months of complete control, we start to stepping down, and we can start stepping down, taking out the antihistamines or increasing the interval of omalizumab depending on which drug the patient is, which step the patient is. Unfortunately, most patients are still treated with non-recommended drugs, as you can see in this graph. Anti-leukotrienes, oral corticosteroids are present in 20% of the prescriptions of patients with chronic urticaria, and they are not recommended anymore for treating chronic urticaria. The guidelines recommend to use a second-generation antihistamine as first-line treatment because of the side effects that you all know of the first-generation antihistamines. It interferes with sleep, with capacity of learning and many other skills because of its effect on the central nervous system. The guidelines also recommend updosing second generation antihistamines and not use different antihistamines at the same time. As you can see in this graph, updosing the same antihistamine is more effective than combining two different antihistamines. And those antihistamines listed here, bilastine, cetirizine, desloratadine, ebastine, fexofenadine, levocetirizine, and rupatadine, are the antihistamines that we can use in up to 4-fold doses. Well, this is one of the papers that support the recommendation of updosing omalizumab or reducing the interval between doses. It's effective, but sometimes, at least in my country, the access for higher doses of omalizumab is difficult. So a few patients could have these higher doses to treat when they do not respond to the 300 milligram dose. In summary, this is what we are doing in our group, and this is what most of the UCARE centers are doing. When the patient is a non-responder, we can increase the dose of omalizumab. If even with higher doses the patient does not respond, we stop omalizumab and reassess the diagnosis. When the patient is a partial responder, that's why it's important to use the UCT. We can increase the dose, and if still not responding, we associate cyclosporine. When the patient is a good responder, we keep the dose and interval, reevaluate every 3 months, and when this patient becomes a complete responder, we can increase the interval between the doses of omalizumab, reassessing every 3 to 6 months, and if the symptoms get worse, we just go back and short the interval again. Some other suggestions or recommendations of the guidelines: the antihistamines should be taken regularly, not as needed. Do not use higher than 4-fold doses. They are not more effective than 4-fold doses and could induce more adverse effects. It's impossible to recommend for or against H2 antihistamines. There is no enough evidence in the literature. The guidelines also cannot recommend any other treatment because of the lack of evidence. We suggest the same algorithm of treatment in children and the same algorithm in pregnancy and during lactation. Just to show you some of our experience, this is a research that we did in our group where we compared the response to antihistamines between adults and children, and we can see in this graph that children respond better to antihistamines than adults, and the same was seen in patients from Korea and China. And regarding urticaria and pregnancy, this is a big study from the UCARE network. 21 UCAREs involved, including Brazil and India. 13 countries. We assessed many aspects of urticaria in pregnant women, and it's interesting that 51% of the women with urticaria gets better during pregnancy, just 30% get worse. So during pregnancy, it's not uncommon for us to stop treatment for urticaria because most of the patients get better during this time. So the last part of the guidelines shows us some other drugs or interventions that are frequently or not so frequently used around the world, like antidepressants, pseudo-allergen-free diets, other immunosuppressive drugs, but there are lack of evidence for the use of all of these drugs in chronic urticaria patients. We just use them if all of the others, like antihistamines, omalizumab, and cyclosporin, fail. I'd like to end this presentation inviting you for the Global Urticaria Forum next December in Berlin, and next year the UCARE meeting and preceptorship in my country, in my city, São Paulo. You are all invited to join us there. This is our group at the Federal University of São Paulo. You are also invited to visit us whenever you need. Just let us know, and it will be our pleasure to have you with us for 1 day, 1 week, 1 month. We are always open for visitors to share experience with us. Thank you very much. I don't know if we have questions now or later.
Sir, thank you for your informative lecture. I think questions can be entertained during the panel discussion.
Okay.
So you may be kindly seated, sir.
Thank you.
Introduce Bhavik. First. Right. That's all.
So, next is a panel discussion on urticaria, moderated by Dr. Nidhi Sharma. So now I invite Dr. Nidhi Sharma. She doesn't need any introduction, but nevertheless it is my duty to say. So she is a consultant dermatologist at Medanta Medicity in Gurgaon, and she is a treasurer for the Skin Allergy Research Society, a deputy editor for Indian Journal of Skin Allergy. So over to Dr. Nidhi Sharma.
Thank you, sir, for the kind introduction. CVs of Next. Let me listen. Now I would like to invite the panelist on the stage, Dr. Louis from Brazil, sir. Dr. Kiran Godse, sir. He is the professor of dermatology at Dr. D.Y. Patil University and School of Medicine, Navi Mumbai. Dr. Mukesh Girdhar sir. He is Associate Director, Department of Dermatology, Max Super Speciality Hospital, Delhi. Dr. Sushil Taliani sir from Mumbai. Dr. Anant Patil sir, Associate Professor, Department. Starting with the panel discussion, urticaria behaves differently in children than in adults, differently in females than in males, and there are various types of presentations of urticaria angioedema. It not only affects because of the symptoms, but it has effect on the personal, professional, emotional, and financial life of a patient. This is the recent data where the incidence of chronic urticaria and inducible urticaria is shown. However, data of India is missing. But the overall, the Asian continent, it is 1.4% of incidence. With this background, I'll start my panel discussion. We have been listening a lot on the two types of urticaria, subtypes of chronic urticaria, type 1 and type 2. Dr. Kiran Godse sir, how would you simplify two endotypes of urticaria?
Yeah, so now picture is very clear. Our urticaria first used to say only autoimmune, now it is autoallergic and autoimmune. And Dr. Louis also told just 4 tests you need to do: IG, anti-TPO, CBC, CRP, ESR, which will give you an idea whether you are dealing with a autoallergic type or autoimmune type. So a positive anti-TPO and low IG will point you that this patient is a autoimmune urticaria. So here cyclosporin will be a third line. Whereas reverse of that, higher IG and negative anti-TPO, it pointing towards a autoallergic type. So here after your this thing, a steroid or omalizumab will work. So that gives a lot of idea, but still I do see patient doing prick test and allergen test and so many tests, but our guidelines have recommended just 4 tests to give you idea what you are dealing with. So that is a short summary about this thing. Dr. Louis, anything you have to add?
No, I think that's the point. I just like to stress that we don't have to investigate allergies for patients with chronic urticaria. That's the most important. Unfortunately, we see a lot of colleagues doing that, not just in Brazil, but in other parts of the world.
Right. Dr. Louis, sir, how do you optimize omalizumab treatment in patients of chronic spontaneous urticaria? When do you updose it? When do you taper it?
So as I showed you in my presentation, the first thing is to control the disease. So when we start omalizumab and the disease is controlled, we wait for, in general, 6 months in my practice to start down dosing. We don't down dose, we increase the intervals. What happens sometimes, I didn't show you, but some patients stop taking antihistamines after they control their symptoms with omalizumab. They stop by themselves. And we checked these patients, and we see that most of them keep their symptoms controlled even without antihistamines. So this is not recommended by the guidelines up to now, but in my practice, what I do is after the patient is controlled with omalizumab, I start down dosing the antihistamines, and when the patient is controlled just with omalizumab without antihistamines for 6 months, I start to increase the interval between doses from 4 to 6 weeks. Then we have 2 options to just move to 8-week interval. So 4 weeks to 6 weeks, the patient is okay. Then 8 weeks, then we stop. This is one way. The other way, for those patients who are not so confident, we can keep the dose every 6 weeks for 3 doses, like 6 weeks, 1 dose, 6 weeks, another dose, and so on. And after 3 doses with this interval, we increase to 8 weeks for 3 doses more, and then we stop. If the patients relapse during this process, we wait for more 3 to 6 months with the dose that is controlling the symptoms to start again this increase in intervals.
So what is the maximum dose you can give to a patient, omalizumab?
600 milligrams per month. As I said, we have little experience with these higher doses because the access is difficult. I may have like 4 or 5 patients, but in my practice, I just updose omalizumab when the patient is a partial responder. I do not updose if the patient is a non-responder during the first 3 months.
Would you like to add other immunosuppressive or directly updose the omalizumab?
I try to updose. If it's not possible, then I associate cyclosporine. Or if the patient has no response after 3 months of omalizumab, I just stop and change to cyclosporine.
In fact, my patient is taking since 2008. She can afford, and she takes every 3 months 1 injection, and she doesn't take antihistamine. She said, I want to be free from asthma and urticaria. So it is safe in lifetime. There is no immunosuppressant. It's an immunomodulator. Even during COVID times, we don't say that other biologics, well, there is immunosuppression, but this is an immunomodulator. So it can be safely taken. And now we have got a biosimilar also, which is available. And again, you can restart after patient gets worsening. So that can be managed as per the choice and obviously the pocket of the patient.
Just a question on your patient, sir. Is your patient not taking any antihistamines now? Antihistamines have been stopped completely. So that's very strange, actually.
See, that is what Louis said, that we don't tell patient to stop. But patients say that, look, I can afford, I can take injection, I don't want to take. The moment he start itching, he goes and take injection. That is what he does. But obviously, we insist that you must take 1 tablet or half tablet so that you can increase the interval between the two. So we don't advise them to stop, but typically well-to-do patients say that I don't want to take tablet, I'll take just injection.
Going to the next question. Dr. Mukesh Girdhar sir, what is your experience with the biosimilars? How effective and safe are they in your practice?
Okay. This is very, very difficult to say. See, omalizumab was working earlier also. It seems to be working even now also. And we don't have any direct head-to-head comparisons, so it's very difficult to say, but they seem to be effective to me.
In fact, the trial which Reliance did was in the asthma, the bioequivalence study. For asthma, they did the study and they have found to be equally effective. And we have been using a Reliance biosimilar for last 3 years. And it is reasonably effective. Obviously, the gold standard remains the original one, but it gives satisfactory results. Obviously, some people do not respond. That is, you have to updose, but well, it is reasonably okay. It's not like complete zero because it's manufactured in New Bombay at Reliance Life Sciences.
Considering yes sir.
Yeah, so I mean, if a patient is not responding to the originator brand, is not going to respond to the biosimilar, and vice versa also. There may be a difference somewhere in the efficacy wise that somebody is responding maybe 80% with the biosimilar and is responding 90% with the originator. I don't think there is much difference.
Dr. Sushil Taliani sir, what is your experience with Bilastin, with the experience we had in last few years? Where do you place this molecule in your clinical practice?
So it's for people who have comorbidities because it does not interfere, the metabolism is not much affected by any liver disease or renal disease. And it's for people who have a moderate intensity where you can give a standard dose. But for people with severe urticaria, I may have to use a higher dose to begin with, and then I lower the dose once the blood levels are stabilized. So I find it to be a very useful molecule, but maybe in some of the patients it may not respond so well, so I had to use a higher dose.
the label of Bilastine says that it has to be taken after food, 2 hours after food or maybe before food. But the recent study which has been published in I think 2022, it says that there is no difference whether you take with food or without food.
So this is one of the very promising molecule where no dose adjustments are required, and now the double dose molecule or 40 mg of Bilastine is also available in the market. So there are various guidelines, international guidelines, European guidelines, American guidelines. Dr. Lewis, sir, how do you compare or what is the overall difference between EACI and other international, especially the American guidelines?
It's difficult to compare, even because I'm one of the co-authors of the international guidelines. Actually, it's not the EACI guidelines, it's an international guidelines. The Americans in particular, they still use first generation antihistamines, the higher dose they can. So if the patient, they don't care if the patient is going to be sleepy or whatever, they just give them lots of first generation antihistamines. They also associate different antihistamines, first generation and second generation. They use anti-leukotriene, even we know that less than 5% of patients will have some kind of response to anti-leukotriene. And they also recommend using other immunosuppressant drugs. So I don't know, but I have a feeling that the Americans are back in time regarding urticaria. I'm sorry to tell you that, but we see all the world going to one direction, and the Americans stay in the same position and not wanting to join us in the international guidelines. I do not recommend what they recommend. That's it.
Dr. Mukesh?
Yeah, so Nidhi, you have been a part of our Indian guidelines also now. So the guidelines all across are basically they are similar. They talk of updosing of the antihistamines. They may not be agreeing on the quadrupling straight away, but they generally agree on the updosing. American practice parameters, they are more like, Indian practitioners' method of treating the, urticaria patient. You give a combination of 2 antihistamines, you add anti-leukotriene, you give H2 antihistamine. And we have seen, even Dr. Kiran will agree with me, that certain patients of ours, they respond to these combinations very well. They are not responding to one particular antihistamine. I was just discussing Dr. Murli, just now I was showing him one article of the World Allergy Organization. In that article, they have talked about the updosing. They have done the review of the published research and seen that 20 milligram of levocetirizine is not better than 10 milligram of levocetirizine. It's the conclusion of all the 12 studies which they have included. Similarly, when you talk of Bilastine, 20 to 40, it works very well. But 40 to 80, it's not that much of difference. So that is why it does make sense to combine, maybe Bilastine in the morning and levocetirizine at night. And 10% of the receptors are H2 receptors. So if the patient is responding well but not very well, then you may add H2 antihistamine also. So I would say that sometimes we have to digress from these international guidelines and use the other parameters also.
So do you add H2 antagonist for your patient? Yes, sir.
No. See, basically on what you see on the one side, it is on the evidence, on the other side is the experience. So obviously, evidence and experience you have to combine it too. So our Indian guidelines, we have combined evidence and experience. So we do recommend giving the two together, but that is just because we understand Indian psyche, and our Dr. Google is always there on the back of our head. So the moment I write levocetirizine 4 times, patient will come back to me, say, doctor, what have you written? So that's how we have realized that. And even the study shows that 2 tablets of Bilastine in the morning and 2 in the levocetirizine in the night. That is what we recommend for the convenience. Obviously, the studies say otherwise. Dr. Louis, what you are saying?
I'd like to stress that the guidelines is a living document. So as you could see in my presentation, it's changing along the time, and it's an evidence-based document. So when we have evidence that combining two different antihistamines, maybe the guidelines can change, of course. That's it.
See, there is one study, Dr. Louis, which you mentioned in your presentation, the updosing comparison, 2 antihistamines, double the dose, and 3 antihistamines, double the dose, compared with 4 times the dose of one antihistamine. Now, I have looked into that study. That study is actually on pruritus. That's not on urticaria. That's a German study. And what is happening there is the antihistamines which they have used acrivastatin. I think that's even, yeah. So that's a very old study. And that actually talks about pruritus cases, not urticaria cases. It's an old study. Yeah.
Dr. Sushil?
So I agree with Dr. Lewis that when we say experience, that experience is not backed by any evidence. It's a real world experience, but then medicine is an incomplete science. We are stating in guidelines the current truth, which may again change. So yeah, when we recommend something which is according to guidelines, we are also medically safer because we are able to quote.
Just another comment. It's important to remember that the guidelines can recommend, it's very strong, or suggest, it's not so strong. So the use of combining antihistamines is a suggestion because of the level of evidence.
Dr. Anand Patil, sir, what are the new options to look forward now? So basically, omalizumab and ligelizumab. So how would you compare these two?
I think the science is evolving day by day and we are understanding more and more. So as one of your presentation also showed about the data on ligelizumab, it seems to be a very promising molecule in terms of both potency as well as the duration and the amount of suppression that would offer to the patients with CSU. So I think ligelizumab is one of the options to look forward to. We don't have this molecule as of today in India, but yes, it has a promising future. But again, there are so many other options also coming in pipeline, although they are not on the board as approved molecules. But there is one molecule, or the class rather, I would say, these tyrosine kinase inhibitors, the splenic tyrosine kinase inhibitors as well as the Bruton tyrosine kinase inhibitors. And similarly, some monoclonal antibodies in addition to ligelizumab. We have something coming in IL-1 antagonist, IL-5 antagonist, the splenic tyrosine kinase inhibitor. I don't know how it will work, but this is a topical formulation. As of today, we don't have anything for topical formulation, but one of them is in pipeline. So let's wait for that and see what the result.
Dr. Patil, we did just finish the ligelizumab study. So we don't know which is which, but we know that it definitely works better than omalizumab, that is for sure. And fenibrutinib is one of the molecule which I am very excited. What is, Louis, your take about the fenibrutinib, which in fact German study, they just published study?
Well, I actually can't say about these drugs because I have no experience. I just read the abstract of the studies. But if you allow me, I'd like to say something about ligelizumab. Ligelizumab was a promising drug because Novartis just stopped the development of the drug for urticaria because of the phase 3 studies. So that's what we see in science. We had a promising drug in phase 2 studies, but phase 3, it wasn't different from omalizumab, so they decided to stop. And so now we have a lot of hope in BTK inhibitors, but as you can see, there are many other potential treatments especially for those patients who do not respond for omalizumab.
Luis, sir, can you give some practical tips for the management of cholinergic urticaria? What are the treatment options and what is the role of biologicals in it?
We treat inducible urticaria the same as we treat chronic spontaneous urticaria. So we start with antihistamines, non-sedating antihistamines, standard doses. We updose until 4-fold doses, 2 to 4 weeks. If the patient does not respond, we add omalizumab. The response to omalizumab in CINDU is not as good as in CSU, but most of the patients respond. For some patients, we have to add cyclosporine or change omalizumab to cyclosporine. But I would say that if in CSU we have 15% of the patients who do not respond to omalizumab in cholinergic urticaria, it's not a scientific data, it's a personal observation. It's more than 15%. So around 30 to 35% of the patients do not respond to omalizumab. Then we try cyclosporine for these patients as is recommended by the guidelines. That's my experience in cholinergic urticaria.
Any other panelists would like to add?
Actually, this we see typically in October and April, May. Bombay people say that I go out and I start scratching. I come back home and I'm okay. You know, that is typically October heat is the dangerous, especially in Mumbai. So we do see, but patient tries to learn that they know that if I go in sunlight, I'll start scratching. So they try to stay indoors, stay cool. And obviously the antihistamine does work in most of the time. If not, obviously omalizumab is the answer.
In cholinergic urticaria, especially the exercise-induced component, I have seen if you encourage the people to go for walks and they gradually increase the period of their walk, they overcome quite a bit of it. I have seen people who have lost habit of walking, they develop the cholinergic urticaria the next season. They start walking within 2 minutes, it happens. So I tell them to keep doing that regularly. So gradually they are able to increase the time to 5 minutes, 10 minutes, and even half an hour walk then doesn't cause any urticaria to them. So you can develop, a kind of tolerance to this. Yes, that's possible.
And sometimes they overcome it also. It just resolves after a year or so, and they can do the same activity without any problem.
Dr. Mukesh Girdhar sir, how do you counsel patients for planning for pregnancy? Do you stop antihistamines, wait and watch?
Yeah, so this is a very tricky thing actually. Now somebody, if that patient is on 4 times the dose of antihistamine, you cannot stop altogether, right? The first thing is I try to reduce the dose and I try to come to the double the dose first. Once I have achieved double the dose, then I try to combine with the 2 pregnancy category B antihistamines, 1 dose in the morning, 1 at night. So that's how I am, legally in the right position. If I am able to control urticaria on 2 doses of antihistamine, 1 in the morning and a different one in the evening, like for example, loratadine in the morning and cetirizine at night, then if I am able to control with that much of dose, I will give them go ahead to go for pregnancy.
And what during acute exacerbations during pregnancy? How do you tackle it?
Yeah, so again, tricky thing. See, updosing is not recommended in pregnancy, that's one. Then you have to go for the old generation 1 American parameters thing, chlorpheniramine maleate, that is still available. So I rely on that then.
So this is one of the UK studies. Dr. Gotse sir and Dr. Louis sir are the part of it. It can either get worse, remain same, or it can improve. But there is no effect on the neonates or newborn baby.
In fact, just like to tell you that, remember, half of patient will improve. That's the beauty of it. 1/3 will have worsening and 20% will be unchanged. So typically, I always say pregnancy is a better thing. Half the chance that you will be free or at least your intensity will come down. And you can, in fact, few of my patients have delivered with omalizumab on. It's this thing. So that is also optional. But obviously, we don't recommend updosing because the gynecologists don't like double dosing. So that's the thing. But good part is half of patient do improve.
No, I just think that as half of the patients improve during the pregnancy, it's not difficult to start down dosing the antihistamines. And regarding omalizumab, we continue during pregnancy, but in my practice, what I do, I do not follow the guidelines for this. I leave the omalizumab for them just as needed. That means the patient becomes pregnant, So I wait for the symptoms to appear to give them the next dose of omalizumab. So the patient generally takes like 2 or 3 doses of omalizumab during the 9 months of pregnancy.
Dr. Sushil Teliani, sir, what are the common comorbidities you see in patients in chronic urticaria?
First of all, the comorbidities where we blame allergies, like for example, they have allergic rhinitis, many will be asthmatic, you see more atopic eczemas, dermatitis, but you also tend to see sometimes autoimmune diseases described and depression. We are not sure whether the causally related, sometimes the depression could be the effect of the urticaria, but it is found to be more common in people with, these are the ones that I normally see.
Any other panelist?
Just to tell you, somebody having a metabolic syndrome will have urticaria which is severe, will not take respond, will take longer time. That is one of the prognostic factors, There are 6 prognostic factors where patient will respond, will take long time to respond. Typically females with higher age, concomitant inducible urticaria, concomitant angioedema, then the metabolic syndrome, then anti-TPO positive, and even NSAID hyperreactivity. If your patient has got any of these points, this patient will respond, will take longer time to respond, and the urticaria will last longer. That is the prognostic factors, and in which she already mentioned the emotional stress and anxiety. Well, it is well-known fact.
And many of them sometimes will tell you the aggravation caused by certain foods, the so-called pseudo-allergen aggravation in people with urticaria.
So coming to a case, the patient is a 60 years old male with itchy evanescent rashes for 8 months. There was history of few episodes of swelling of eyelids and lips with no difficulty in breathing, no history of aggravating or relieving factors, no history of known allergy to food and drugs. There was no history of inducibility. Patient is a known case of diabetes mellitus since past 2 years and was on treatment, tablet metformin 500 mg once daily. Patient is a known case of hypertension since past 5 years and on irregular treatment, tablet amlodipine 5 mg. Past treatment history includes all antihistamines, loratadine, levocetirizine, even ranitidine, deflazacort, montelukast, injection histoglobulin, injection phenyramine maleate, and injection hydrocortisone. On cutaneous examination, dermographism was present and the testing for inducible urticaria was negative. The urticaria activity score was 32. Urticaria control test was 8. Lab investigation, the complete blood count was within normal limits, CRP within normal limits, thyroid stimulating hormone 5.7, anti-TPO antibodies within normal limits, serum Ig 700, HbA1c 6.8, liver function, kidney function, urine routine microscopy, they were within normal limits. So diagnosis of chronic spontaneous urticaria was made and patient was treated with 4 times second generation antihistamine with partial response. ASST was positive. Dr. Luis, sir, what other workup is necessary in these kind of patients?
If you can go back a few slides just to, yes, on that one with the lab tests, please. So anti-TPO negative. I would not do any other tests for these patients. It's okay. We have high IgE, low anti-TPO. We have positive dermographism. For me, this patient has CSU plus dermographic urticaria. I just like to stress that in this case, maybe the UAS7 is not the best choice because it doesn't assess inducible urticaria, just CSU. And as this patient has dermographism, the UCT would be better because it assesses both types of urticaria.
So actually, just these 4 tests will give you guidelines. The moment you see high Ig and negative anti-TPO, you know that you are dealing with mostly autoallergic type. So here, obviously, if patient can afford, omalizumab is the answer. If not, then you can give other drugs like cyclosporin, methotrexate, or sometimes even pulse steroid you can do for just 2 to 4 weeks. Somebody who can't afford anything else, you can, what we do for lichen planus or any other autoimmune disease, you can try. But typically, the omalizumab should do well in this patient. And again, if you do a CBC with 5-part differential, eosinopenia and basopenia, if you see, they are indicator of a autoimmune disorder. So that you do, and high CRP again towards autoimmune urticaria. So these 4 tests should give you lot of things, and actually you can be sure that I am dealing with either autoallergic or autoimmune, and you have to take it further. You can't stop the disease. What I said, you douse the fire. That's what you can do.
So now we don't recommend battery of these tests, just these 5 tests are sufficient. Dr. Mukesh Girdhar sir, why some patients are unresponsive to the standard doses of antihistamines?
Yeah, so histamine is not the only thing which is, responsible for urticaria. There are other mediators also involved, so that is the reason why, even the updosing doesn't help. Why some patients respond to just single dose of antihistamine, and why some patients don't respond to the 4 times the dose of antihistamine. So those are the patients who have other, mediators also involved. So you need to treat them with the other medication like omalizumab or immunosuppressives or immunomodulators, and maybe anti-leukotrienes depending upon the other comorbid situations and the findings. Yeah.
Dr. Sushil Deliani sir, this is a case where patient had other problems like diabetes and hypertension. How do you manage your patients with comorbidity?
So, if the patient can afford, as I said, in this situation, you should be using anti-Ig monoclonal antibody. If the patient cannot, and if you use an immunosuppressive, I'll just involve a physician and I'll manage the comorbidities. It does not mean that we should not use cyclosporin at all, except if your creatinine is way above the normal. And this is one situation where sometimes I have a patient who's got both high IgE and positive anti-TPO. I can still use omalizumab, but there is a situation where you see negative Ig is within normal limit and anti-TPO is also negative, and patient has got resistant, which does not respond to 4 times the dose. Those are situations where I am at a loss because there is no guideline to tell me how to proceed further. So empirically I use, and when I use in my practice, I try to avoid omalizumab except if the comorbidities allow, because patients may not respond. And when the patients are out of pocket expenses, they become more demanding as to why they are not doing well. So I would like to have the co-panelists to guide me, because I have seen situations where I have normal Ig levels, anti-TPO is negative, and patient has not responded 4 times, and the patient has urticaria, chronic spondylitis. Anything that you do in such situation?
Actually, I prescribe omalizumab for all the patients that do not respond to high doses antihistamines. Even if the Ig is low and the anti-TPO is high, I think we should try, because some of them will respond. The difference is that for the patients that have low IgE and high anti-TPO or low anti-TPO, I just don't wait the 6 months of omalizumab for a response. I wait like 2 to 3 months. If there is no response, I just give up and move to cyclosporin.
I've had 2 patients who have been on immunosuppressants and they can't even afford cyclosporin. Some of them are financially challenged, so I have had to manage with methotrexate, 15 milligrams subcut, and it seems to be working fairly well.
My personal experience with methotrexate is very bad. All the patients that I tried, it wasn't so many patients, maybe 8 to 10, but none of them had a good response. That's my personal experience.
Yeah, so on methotrexate, as the first timer in the immunosuppressive drugs, when you use it as the first drug after the antihistamines, in quite a lot of patients it fails. But in some patients, but I have found it most useful in weaning. It has not stopped cyclosporin, and I've shifted to methotrexate. The remission has been maintained with methotrexate. So methotrexate sometimes works.
Actually, there is a corollary to this. In fact, Dr. Grattan has shown that cyclosporin is the only drug which can induce remission in chronic urticaria. Otherwise, none of the drugs can induce remission. So when you give cyclosporin, it actually suppresses the autoantibodies, and your treating urticaria becomes easier afterwards. So as you rightly said, after cyclosporin of 3 to 6 months, you can switch over to something else, because by the time you have reduced your autoantibodies, circulating autoantibodies, so treatment will be easier. So often first cyclosporin and then anything else does work.
But what if the patient already was in remission and would have done well without methotrexate also?
Yeah, that is also possible.
So the last question for the day, continuous versus on-demand treatment with antihistamines in chronic urticaria. Dr. Anil Patil sir, what's the pharmacological basis to it?
I think I would go with the guideline, because one of the slides what he mentioned was treat the disease treat the patient until disease is gone. That itself means that patient has to be treated continuously, and also there is a pharmacological basis for it. Traditionally, the the histamine receptor was supposed to be called as, the antihistamines are called as antagonist, but actually they are not the antagonist. They are called as inverse agonist. So what is the difference between antagonist and an inverse agonist? So there is a two-state receptor model. So one stage is the binding for the active, and one is for the antagonist. So when you have a histamine, it binds to the active site and changes the confrontation to the active site. So when you give antagonist, it is a lock and key model. But it's not the lock and key model, so it's an inverse agonist. That means it will act on the inactive site, and it will change the confrontation to the inactive site. So irrespective whether histamine is there or not there, when you give antihistamine, the confrontation is going to change to the inactive site. So that is why the concept also supports the continuous use of antihistamine rather than on demand.
Thank you, sir, for explaining it so nicely. Now we can have some audience questions.
And also, in allergic rhinitis, there is a concept called as minimal persistent inflammation. There also they recommend for longer duration. I think same concept possibly can be used in CSU.
Yeah, it's not a question. In fact, I just wanted to, add something to the current discussion which is going on. Dr. Mukesh said very categorically that, some of the patients who cannot afford, of CSU, cyclosporin treat with methotrexate, we treat with methotrexate. My experience being the same, but Dr. Lewis said he has not seen at all any good result. In fact, this is the picture for not only chronic spontaneous urticaria, for atopic dermatitis also. When we discuss in International Eczema Council, we have seen there is various types of response, varied response. The reason being, methotrexate works on dihydrofolate reductase enzyme, and this enzyme has got tremendous genetic polymorphism, and it varies in different regions, different population, different ethnicity. So much of variants are there. So some variants they do respond to methotrexate, some variants they do not. So it is not surprising that some of us are getting good results. Some of us, in India also, some of our colleagues they are not getting good results in methotrexate, while some others are getting, because we have got more than 2,000 ethnic populations as a hub. India as a hub of 2,000 more than 2,000 ethnic populations. So it is not difficult to understand why some patients respond to methotrexate while others are not.
Point well taken, Dr. Sandeepan. Thank you for enlightening us. Dr. Timbadi.
What is the role of H1, first generation H1 antagonists like Atrex and all, hydroxyzine? In acute urticaria, it has been seen that anxiety plays a very important role in exacerbation, and hydroxyzine is known to work as anti-anxiety drug.
Hydroxyzine in urticaria and anxiety. Acute urticaria, okay. Well, I personally do not recommend using hydroxyzine for any patient because of the side effects. Hydroxyzine is not better than other modern non-sedating antihistamines. So the only situation that I could recommend using first generation antihistamines is at the emergency room, because the only injectable antihistamines that we have is diphenhydramine, and it's a first generation. But just in emergency, in any other situation, I would avoid using hydroxyzine or any other first generation because of the side effects.
Dr. Maria, so I have another take on this actually. See, hydroxyzine has a half-life of about 24 hours. So when we give it at night, it's not that the effect is going on in the night itself. It's going to be sedating all throughout the day. So if you want to give some anxiolytic, you give an anxiolytic rather than giving hydroxyzine at night time. Yeah, it varies from patient to patient. Some people get
no
sedated.
sedation at all, and as soon as the urticaria regresses, even half the tablet causes sedation.
See, sedation is one part of it, anticholinergic side effects another part of it. Psychomotor slowing, if we go, accept the studies which are done, there is some psychomotor slowing anyway. Now, whether it is a person who is working, in the office, or a student going to the school, or a lady going to the office, somewhere it is impacting the performance of the person. So that's how, I will rather want to add an anxiolytic at night rather than giving a sedating antihistamine.
Do you recommend Ig level estimation in all patients with CSF? The guideline says, but is it required for all patients or only if you are planning for omalizumab?
See, in last guidelines, we never said Ig and anti-TPO. These guidelines, because of the studies, we say every patient please do Ig and anti-TPO apart from CBC, ASR, CRP. Obviously, you can do thyroid and sugar as optional, but typically it gives us a guideline. But let me tell you to corollary to that Ig can be raised due to tropical eosinophilia, due to chest diseases, due to worms and so many other things. So obviously it has to be taken with due diligence that it may not be truly representative of the allergen exposure, but typically our guidelines do recommend and we do get some correlation.
Thank you.
I normally do in real world, to be practical, only if the patient doesn't respond to antihistamines. If they respond, then I don't do. If they don't and I have to take a decision, that's when I do.
I just like to stress, especially for the young doctors, that the most important is for us is to know why we are asking for one or other blood test. So, okay, the guidelines says that, but why? And that's the most important. We must know why we are asking for the blood test and not just ask and then we have a result and don't know what does it means.
Dr. Hariharan, and then last question from this. Dr. Hariharan.
In very severe urticaria, we do give steroids. Now there are different types of steroid available: prednisolone, methylprednisolone, and betamethasone, dexamethasone, which is the ideal one to be given and what dosage.
Yeah, I'll just repeat what he said. Urticaria, we do recommend short course of steroids for acute exacerbation. So, which is the preferred molecule? Either prednisolone, betamethasone, or triamcinolone.
The one that I prefer.
Yeah.
Well, I use prednisolone, but it's my personal experience.
Yeah. Next question.
Hello. Yeah, sir, in Indian scenario, how do you counsel your patients about food in urticaria, acute and chronic, sir? Well, how to go about it? Patients are convinced that food is the cause for it.
Yeah, so acute, well, there could be a cause. Patient says, I take pav bhaji, I get urticaria, I get prawns, I get urticaria. So you can see within 2 to 8 hours, patient will start itching. Chronic urticaria, true food allergy is less than 2%. So we don't recommend, don't tell the patient to stop eating 1, 2, 3, 4. Tell him to continue eating what you're eating from birth at home, but avoid, what we tell to avoid is colorants, additives, preservatives, dyes, chemicals. So in short, the colored food which you get from Swiggy and Zomato, that is what we tell them not to take. And the food which is colored, Chinese bell, red color thing, canned food, this is what we tell about. But please don't tell the patient to stop eating brinjal, fish, seafood, don't tell, especially for chronic urticaria. Acute urticaria, patient will find out what is the cause. He said, I ate pav bhaji and I got it. So you stop eating pav bhaji. It's not the tomato, it's a colorant in it, or maybe tomatoes in high contents can cause. So obviously acute food is yes, but chronic, don't tell them to stop many things. Yes, Dr. Bose, last we have got. Yes, sir, Bose, we miss you at there, this thing. Just wait 1 minute, we'll get the mic for you.
So can you use the mic?
Hereditary
Mic.
angioedema. Hereditary angioedema. So you want radical.
All the three medicines that I mentioned failed. So what we are going to use? Any biologic or any other? Hereditary angioedema. Tranexamic acid.
Okay, I got it.
Stanozolol,
Yeah.
Danazol failed.
Yeah, so Dr. Bose has asked about the hereditary angioedema. Now remember, angioedema without wheels, please think of hereditary angioedema. We don't have ICAT band, we have just got one radical inhibitor in the market, but otherwise we have to rely only on tranexamic acid, stanozolol, danazol and fresh frozen plasma. Unfortunately, we don't have ICAT band or any of these inhibitors. Just now one company has launched a biosimilar, but otherwise we have got only these three options. Yeah, it is just launched by, I think by Cipla, which is available, which is cost 35,000. Role of adrenaline, this is the last question we are taking. Role of adrenaline, Dr. Mukesh.
We use only in anaphylaxis, yeah. Point.
So remember,
Sub-Q
the
you have.
angioedema due to anaphylaxis, you give adrenaline. Angioedema due to chronic urticaria, you can give your regular antihistaminics and steroids. If there is a choking sensation, you may consider adrenaline.
So I had a call in an emergency room for a person who was having a sandwich with lettuce and he collapsed and he had a swelling on the lips and all. So that's an indication where the blood pressure drops, there is bronchospasm or any GI problem in addition. For those systemic manifestations, you should use adrenaline or epinephrine as a life-saving drug.
So we end our panel discussion here. Thank you all the panelists for the insightful discussion. Thank you Team IPCA for organizing such a wonderful event.
Could you request the Dr. Kiran Godse sir to felicitate the chairperson for today's first session, Dr. Rajendran sir. Dr. Rajendran sir. He's can I call upon next our panelists for today's discussion, Dr. Mukesh Girdhar sir on stage, please. Dr. Mukesh Girdhar sir, please. Dr. Sushil Tehliani sir. Dr. Anand Patil sir. Yeah, Dr. Rajendran SSR, please. Our wonderful moderator for today's first session, Dr. Nidhi Sharma. our guest speaker, an eminent faculty from Brazil, Dr. Luis Encina, sir, please. Can we have a round of applause, sir? It takes about 26 hours to reach India from Brazil, is what I've learned yesterday. Thank you so much, sir. And sir, can we have Dr. Anand Patil, sir, fellow state, Dr. Godse, sir? One thing we've learned today is Godse, sir, and his love for pav bhaji is immense. Thank you so much, sir. I'm Dr. Sahil Sethi. Thank you, everyone, for the first session this morning. I'd like to now hand over the mic and the dais to my colleague, Dr. Meghna Singh, to take over the second session this day.
Good afternoon, everyone. I'm Dr. Meghna Singh, and welcome to the second session on atopic dermatitis. Respected faculty and dear delegates, I would like to introduce the chairperson for the second session, Dr. Rashmikant M. Shah, sir, who's the Vice President IDVL 2020. He's been the past president of IDVL Maharashtra. He's the council member of Asian Dermatology Association. Sir, please. Our second chairperson, Dr. Ashok Shah, sir. He's the president, IDVL Maharashtra 2007 to 8. He's the ex-honorable professor of Department of Skin and Venereology Leprosy at D.Y. Patil Medical College. And he's practicing at Ghatkopar Chamber since the last 40 years. Sir, I would request for your presence on the stage, please.
Good afternoon to you all. Dr. Ashok Shah would shortly join as a chairperson along with me. One of the most important topic in dermatology is atopic dermatitis. We have two prominent speakers today in the morning, in the afternoon. Dr. Muralidhar Rajgopalan and Dr. Sandeepan Dhar. And then we will be having a panel discussion. I think first is on the list, it was Muralidhar, but then now probably it has been changed. Who is going to speak first? Muralidhar, Dr. Muralidhar. Dr. Muralidhar, can you remember 11 years back, you had been to Mumbai and we had first CME on immunotherapy. And I was speaking on classification of immunotherapeutic drugs and you were on biologics. And I said, you know what I said, that immunomodulatory drugs are very difficult to remember. And he said that, it is the future. And I still remember. And that future is certainly seen now. Dr. Muralidhar Rajgopalan doesn't require any introduction to dermatologists of India. He is affiliated to Apollo Hospital, Chennai. He has the similar experience of teaching, and I have 34 years of practicing dermatology, and he has an experience of teaching as well as clinical practice. He has plenty of, the numbers here are probably wrong. It is much more than that. He has plenty of awards and papers and presentations and contributions to journal. He is IPC Counselor for India since 2006. He is a member board of director in International Society of Atopic Dermatitis, and so many achievements. Dr. Muralidhar, the stage is yours now.
Thank you very much, Dr. Shah, for that nice introduction and memories down the lane. And thank you. That's okay. Thank you very much, Sam and Dr. Kiran, and all the doctors of Bombay for being here. I've been associated with Dr. Kiran and his team at SAM, and it's a privilege to be speaking on atopic dermatitis. People used to call me as a psoriasis guy. Well, I've been speaking on atopic dermatitis. I have no conflicts of, the mic is gone. I have no conflicts of interest to declare. I have got nothing to do with any pharma company related to atopic dermatitis. But my topic is going to be toxic because this is on pathogenesis of atopic dermatitis. What is the recent inputs that we have? We start off with how genetic risk genes and environmental risk exposures may interact and impact the risk of atopic dermatitis. We are all aware about the genetics, and people keep talking about the genetics of atopic dermatitis. But then we start talking about how the environment also impacts it. And today we know that these are interlinked. If you look at this chart over here, there is an increased risk. As the genetic risk goes up and as the age goes up from birth, the decreased risk is when there is exposure to dogs. Like there's a very interesting study where they say cats reduce atopic dermatitis, older siblings, rural living, increased UV exposure, premature birth, thymectomy, because those T cells are not produced which produce atopic dermatitis. But the risk goes up in cold temperatures, ambient humidity which is low, air pollution, indoor chemical exposure from home renovation, and high calcium content in the domestic water. I think all of you over here will be familiar that this is what happens in most of our atopic dermatitis. So there is a threshold which is crossed and manifestations occur, but there is a huge area which is subclinical. So this is very unclear as to whether it is because of Staph aureus, the gut and skin, the dietary habits, smoking and alcohol. Today I am going to talk a lot about the microbiome and the gut so that these areas that are unclear become a little clearer. The atopic dermatitis pathogenesis, earlier people felt it was just something which happens in the barrier, and then they said no, it's a purely immunological disease. I introduced in the previous slide about the genetic versus the environment, but actually the whole thing is interlinked. When there is itching, there is skin barrier defects, the microbiome gets affected, the Th2 and Th22 adaptive immunity comes into play, and all these interact with each other. The interaction produces both epithelial defects, which is what was earlier called the outside-in hypothesis, and also the Th2 responses are brought in, which are earmarked by these cytokines, the IL-4, IL-13, IL-5 and IL-22. So this is where you have the memory T cells being produced against airborne or contact or food allergens, microbes, and even self-antigens, which is being recently explored now. Now, there are important skin barrier changes. You don't have to get puzzled by this toxic diagram over here. I just want to focus on this. This red pyramid are the antigens. So as time passes, the antigens start getting deposited on atopic skin, and the keratinocytes also change. You have keratinocytes with the keratohyalin granules, and then you have keratinocytes with the normal tight junctions, and then you have keratinocytes with the normal filaggrin and low filaggrin. Now, what does all this actually mean? What is happening at the barrier? So, the innate and acquired inflammation in atopic dermatitis leads to downregulation and degradation of filaggrin and the tight junction proteins. So this is both the innate and adaptive immunity. So that is down-regulating filaggrin and tight junction. So this leads to a dry and leaky skin barrier with an elevated pH. So you can directly see the clinical correlation that when people have a atopic tendency, there is a very dry skin. This allows bacteria to colonize the skin and allergens, irritants and microorganisms to invade the skin. The tight junction reduction, I'll show you a picture before this, after this. It further allows antigen presenting cells to move upwards and meet the antigens, which I showed you in the previous picture is deposited on the surface of the skin. The lipid synthesis is compromised at several levels throughout the skin. This worsens the barrier. There is an attempt to restore the skin barrier and prevent excessive water loss. Acanthosis therefore occurs. So that is why the skin starts thickening as it becomes chronic. So that is the later phases of atopic dermatitis when there is a switch from the Th1 to the Th2 cells, and that tends to persist for life. Now this is often in conjunction with mild spongiosis, which you see on histopathology. Now this is the atopic skin barrier, which is the key. This is what I was talking about. The granular cells, they move up and the profilagrin gets expressed in this area of the skin, and in the upper areas of the stratum corneum, the keratin filament aggregation occurs and free amino acids are released from the profilagrin, and that is there in the corneocytes, and this is what maintains a natural NMF, means a natural moisturizing factor. Now what happens when there is a skin barrier disruption? Now we spoke about itching in the first 2-3 slides. Now people scratch, there is a physical destruction, there is increased transepidermal water loss, the sweating comes down, sebum comes down, the filaggrin is reduced, moisturizing factors come down, the intercellular lipids comes down. I spoke about decreased synthesis, and the tight junctions therefore get disturbed. So there is a decreased level of total ceramides, and that's why you find in therapy people are talking a lot about ceramides. There is a decrease in natural moisturizing factors due to the expression of filaggrin and abnormalities in tight junctions. The barrier disrupted keratinocytes are very potent producers of immunoregulatory cytokines. Now these barrier disrupted keratinocytes are going to produce cytokines, and we'll show you a picture where you will see which are the cytokines that are being produced. Now if you just look at this in a little bit more detail, what I want to show is filaggrin expression and processing in the epidermis, because there is so much talk about filaggrin. But filaggrin is not the only thing you should be talking about. You should, in a much more detailed exposition, talk more about loricrin, involucrin, and several other such markers which happen in atopic dermatitis. So in the keratohyalin granules, you have the profilagrin molecule. Now this is dephosphorylated and proteolysis occurs, and when that happens, you have these amino acids that are being produced over here, and all these are natural moisturizing factors. So that is actually what the profilagrin does. Filaggrin monomers are degraded, they release amino acids, they contribute to the natural moisturizing factor. So that's the importance of filaggrin in atopic dermatitis. Now I told you about what happens to the keratinocytes, that they do secrete certain very important cytokines. You scratch the skin, the itching can be either due to immunological factors or external factors. We've seen all that. There is Staph aureus and allergens. We showed you a diagram of that. But this skin barrier dysfunction induces a type 2 immune deviation. This produces the thymic stromal lymphopoietin, interleukin 25 and 33. This is a very important axis which should be targeted. Probably you'll hear more about that from Professor Sandipandar after this. So this is what actually activates the entire Th2 cycle, and the Staph aureus activates OX40. Hopefully we'll be able to target OX40, and these in turn are going to produce interleukin 4, 13, interleukin 31, which acts on the nerve endings, produces further itching. So this huge cycle just keeps continuing, and there is inflammation, and you see later on a switch to Th1, which produces thickening acanthosis of the skin. There is a neurocutaneous link in the atopic itch. A few weeks ago, I showed this diagram in the midterm account. Those who are there might remember this, because I showed this mainly to emphasize one very important factor. The free nerve endings exist in the epidermis, papillary dermis, and around skin endings. They are activated by the endogenous and exogenous pruritogens. We have all these that are produced by the keratinocyte, but if you see this nerve ending here, this is a non-histaminergic neuron, and this goes right through from the spinal cord into the brain. You also have nerve endings which are histaminergic. So merely blocking itching with antihistamines in atopic dermatitis is not going to work. This is where you might need other drugs to block the itching in atopic dermatitis. So epidermal hyperinnervation or elongation of sensory nerve fibers causes the itching and sensitive skin. There is a balanced homeostasis between nerve elongation factors, what we call as NGF, and then there is a nerve repulsion factor, what is called as SEBA4 3A, that is SEMA3A, that is, I showed you in the earlier diagram, it was there in the epidermis. These are all produced by keratinocytes. So you see, a keratinocyte is not just a silent spectator in atopic dermatitis. It's a very active molecule. It's a very, very active player in the whole story of atopic dermatitis. It produces so many interesting molecules. Sorry, I tend to have a bit of a tremor, so sorry. There is a lower threshold of the sensory nerve fiber activation that enhances the sensory nerve excitability. So there is abnormal itching even due to a normally non-itchy stimulus. So this is because there is a hyperactivation of the sensory nerves. In addition to the sensory nerves themselves, the astrocytes, which is a type of glial cell, they are also involved. These astrocytes are present way up in the nervous system and brain. Interestingly, STAT3 is activated in the astrocytes. You know, STAT3 is part of the JAK-STAT pathway. Now, this is present in the dorsal horn of the spinal segment. This corresponds to the itchy area of a lesion. Now, this gives us a lot of reason as to why the JAK-STAT pathway inhibition works so well in atopic dermatitis, because it is helping us to block the itching. Lipocalin 2, which is produced by astrocytes, this is in a STAT3 dependent manner. So this amplifies the itching. So the STAT3 is stimulated, the glial cells are stimulated, lipocalin is produced, the itching occurs, but then the itching starts getting worse. So the basic crux in atopic dermatitis is itching, and itching happens both due to histaminergic and non-histaminergic fibers. The itching goes right up through the spinal cord into the brain, the nerve fibers, and these are all stimulated primarily by the keratinocytes, which activates the Th22 cells. So this is to sum up what I spoke till now. I spoke about filaggrin mutations, but we need to be a little balanced about this. Is it really the primary cause of atopic dermatitis? I was also of the opinion. But actually the role of this mutation is not very clear, which means there is a knowledge gap. There are certain things that we don't know about atopic dermatitis, because it is absent in almost 60% of classic atopic dermatitis patients. Patients who have the mutation frequently outgrow the disease in spite of having a mutation. The filaggrin mutations are also associated with other diseases like ichthyosis, and they may not itch and they may not show all the manifestations of atopy. Atopic dermatitis is shown to have a broad range of terminal differentiation abnormalities. This is what I mentioned earlier. We should be talking more about the role of loricrin and involucrin. These are things we should be talking more about, but we don't know much. This is a big knowledge gap that we have, and hopefully in the next maybe 2-3 years, you'll hear more about this. The microbiome is another thing which I told you I will talk about. Looks toxic, but it is not toxic. The gray bars are non-staphylococcus. So these are all the gray bars. So look at the controls. There is not much of staphylococcus. The staph epidermidis is the blue bar. In a control, you have a significant amount of staph epidermidis, but the pink one is staph aureus. There is a little bit of staph aureus in a control, but at baseline in a flare, it shoots up, staph aureus shoots up. And if there is no treatment, it keeps shooting up. And after the flare, once you have treated, it starts coming down, starts resembling the control. So this shows us very clearly how important staph aureus is. To look at it in a different way, to look at the diversity of bacteria that are present, you have a lesional atopic dermatitis skin over here, you have a non-lesional skin, and you have a healthy control skin. The other bacteria here, look at the diversity over here, and very little staph aureus. The interesting thing in atopic dermatitis is that even in non-lesional skin, you will be able to demonstrate most of the immunological findings of atopic dermatitis in the lesional skin. But in the lesional skin, you have a huge amount of staph, but all the bacteria grow. So there is literally a whole zoo out there of the microbiome. The virulence factors. Why are we talking about staph aureus? Because there are important virulence factors. One is PSM alpha, which stimulates skin inflammation and skin barrier disruptions. This stimulates IL-17A signaling. It's very interesting because IL-17A has not been very well explored in atopic dermatitis, whereas we have seen a lot of it in psoriasis, and we are using drugs in psoriasis for it. Delta toxin, once again, is part of the skin inflammation. This stimulates IL-4 signaling. IL-4 and IL-13 are very important cytokines because they are therapeutic targets, which you will hear about after this from Dr. Sandeepan. There is mast cell degranulation with IgE release, and that goes to the histaminergic nerve fibers. There is alpha hemolysin. This works on disrupting the skin barrier. So the staph aureus sits on top of the skin, releases alpha hemolysin, it disrupts the barrier, allows the staph delta toxins to come in. So it's playing a fabulously interesting role. It's not just an innocent bystander. And that produces keratinocyte lysis. When we talk about keratinocyte lysis, we're also talking about the dissolution of the tight junctions and the ability of toxins to penetrate deeper inside into the dermis. There is enterotoxin, which stimulates skin inflammation, and this is where the gut comes in, and the T cell signaling pathway is activated. So both the outside, the external factors, and the internal factors, you find a role of toxins from staph. There is it by itself promotes clumping. It promotes colonization by producing what we call as clumping factor beta, and that also stimulates cell adherence to the skin. So it is important for us to understand the role of staph aureus and to also understand what staph aureus is doing, how is it doing this in atopic skin. No talk on pathogenesis of atopic dermatitis will be complete without talking about biomarkers. If you look at systemic cytokine activation, all these cytokines, IL-22, CCL17, IL-13, CCL12, 13, they all have been shown to be increased in atopic dermatitis. Very interestingly, they are correlated with disease activity if you look at the SCORAD. Now, what happens when you treat a patient like this with cyclosporin? the whole lot get downgraded. So when you look at biomarker, we are looking for a predictive biomarker. We are also looking for a biomarker which predicts response to therapy, not just prediction of disease, response to therapy also. So if you're going to try out a new drug, is this going to really work well? And that is where you look at a diagram like this, where cyclosporin, a well-established drug in atopic dermatitis, has downgraded this. So these are all modifiable risk factors in atopic dermatitis. So if you integrate the biomarkers from lesional and non-lesional atopic skin, they give you the best correlation with SCORAD. So lesional and non-lesional. There is one test called as a tape test, where you just put a tape on top of the skin and you can evaluate the biomarkers in both lesional and non-lesional skin. We've gone that far in atopic dermatitis. Now, if you were to combine, and if youngsters feel that this talk is too toxic, I think this would be the most important statement for today's discussion from my side. There are 4 serum biomarkers: the thymus and activation regulated cytokine, otherwise called as TARC, the chemokine ligand 17, CCL17, the pulmonary and activation regulated cytokine, or PARC, and you have IL-22 and the soluble IL-2R. They all correlated better with atopic dermatitis severity. Please note that IgE doesn't come anywhere here. The last part of today's discussion will be the gut and skin interplay in atopics. This is an evolving area. There's a lot of work to be done. The development of allergic diseases such as asthma and atopic dermatitis is very closely linked with the gut microbial diversity. Just how we showed you about the microbial diversity in the skin, the gut microbial diversity is also important. Lactobacillus, Prevotella and Snithia species are predominant, the bacterial communities in the gut of naturally delivered infants. But if we do a cesarean section, it becomes Staph, Corynebacterium and Propionibacterium species, which are all risk factors for atopic dermatitis. So this seems to be interesting because we are always looking for ways to prevent atopic dermatitis. So these are all interesting factors. Now, there is an alteration in atopic patients' gut. The diversity is decreased. There is an abundance of beneficial colonies like lactobacillus, which is reduced, but the proportions of E. coli, Clostridium and Staph is increased. So this seems to directly correlate with what is happening at the level of the skin in atopics. So the alpha diversity of the gut was closely associated with the decreased risk of eczema. So the more diverse it is, the less severe is going to be the eczema. So you could probably measure such things in young infants itself. It has also been measured, incidentally, certain markers have been measured in the umbilical cord at the time of delivery. TARC has been measured in the umbilical cord. In early life, the regulation of gut microbial diversity and composition can reduce the onset and development of allergic symptoms, including atopic dermatitis. So this statement formed the basis for the probiotic and prebiotic revolution in atopic dermatitis, which is still being worked upon, but I will not stress more about the role of probiotics because that's against math. We need to learn a bit about toll-like receptors. The skin harbors various cells which express these receptors. They are exposed to microbes and pathogens. The invading pathogens can induce aberrant toll-like receptors. The responses can result in skin diseases, including atopic dermatitis. Staph aureus binds to TLR2. We need to understand this. TLR4 mediated responses are also associated with atopic dermatitis, and this releases IL-23, which is a target. Incidentally, if you are able to increase the expression of TLR3, then it can alleviate itch. So this is where the role of, when you are talking about the expression of receptors in the upper surface of the skin, This is where the role of epigenetics comes in. But once again, that will be too much for the next 1 minute that I have. So there is an association. There is any perturbation in gut microbes leads to invasion of the microbes and the metabolites into circulation. So the pathologic symptoms are mediated through toll-like receptors in distant organs, including, you'll be interested to know, the brain. The dysbiosis results in immune disorders, increases the risk of allergies. There is a crosstalk between commensal bacteria that induce immune tolerance and the host. And if you see here, this is what is happening in the gut. This is what is happening in the skin. And all of them produce toll-like receptor ligands, which bind to toll-like receptors, which induces both adaptive and innate immunity. They have roles to play. You don't have to go into great details of this, but the point I'm trying to make over here is pathogens, viruses, bacteria, they all are going to work through TLRs, and ultimately you are going to probably see a form of therapy which is going to interfere directly with the toll-like receptor. So with this is my last slide. I mean, if you talk so much about pathogenesis and say that you know all this, the question you're going to ask is, can you prevent it? Unfortunately, the research has got skewed totally. Initially, it was how common, what causes it, and then once the question came into how can it be prevented, you find that research kind of gets stymied. People are looking more at mast cells, Langerhans cells, eosinophils, T lymphocytes, IgE, the subclasses, ceramides, cytokines, everything. We are looking at all this, but we are not looking too much at prevention or prevention of atopic dermatitis. That's because we have not yet evolved really reliable biomarkers to look about prevention. So, but I think once we do that, probably in the next 3 or 4 years' time, we will be able to talk about preventing atopic dermatitis, recognizing families at risk, and this research and this tree will be much straighter with more branches. Thank you very much for your kind listening, and yes, I think we'll move to the panel, right? After Sandeepan. Thank you.
Thank you, Dr. Muralidharan. Question will be on the panel discussions.
Thank you.
Thank you.
Thank you, sir.
Hari Om. Good afternoon. Today is, I asked Rashmikant Shah, today is his birthday, but still he has come to the conference gathering like this. Then he said that today our bhais coming from Calcutta, Dr. Sandeepan Da, Dr. Murli and other people are coming from Chennai and other places all over India. That's why I'd be here to learn and see them all. Sandeepan Da, please. He doesn't require any introduction. He is the real bhai of our pediatric dermatology from Calcutta.
Yeah.
Till he sets his life, let me further introduce him as the first writer of a pediatric dermatology book in India. Dr. Sandeep.
Thank you very much. Sorry. Thank you very much, Dr. Ashok Saji, for your kind words, and Dr. Rashmikant Sa. Happy birthday to you also. Right? And good afternoon, esteemed colleagues and friends. At the very outset, I would like to sincerely thank Dr. Kiran Godse Dr. Abhishek Dey and the entire team of Society, Skin Allergy Society for organizing this wonderful conference. The hall is full. It is very inspiring to talk in a hall like that and inviting me to speak. Well, I'm an advisory board of a number of pharmaceutical industries as well as the key opinion leaders of the various pharmaceutical industries. But as far as this presentation is concerned, there is no conflict of interest. As my topic is how do I manage atopic dermatitis in Indian scenario, I thought this is very important disclaimer which I should make it very clear to all of you that what I am going to talk to you is not about what is written in the book or journal, is my experience of treating a patient, specifically mostly a child, because atopic dermatitis is a disease of the pediatric age group, in my clinic or in the hospital OPD, and the patient who is not a part of any project or thesis or clinical trial. So that's why this disclaimer that I do not go by any diagnostic criteria while diagnosing atopic dermatitis. Any dermatologist of 4 to 5 years of experience can diagnose atopic dermatitis very easily. I do not assess severity by any severity scoring system. That is not needed. Looking at the child, we can make out what is the grade of severity by and large. I do not follow any guidelines while planning treatment. I follow my own guidelines, and because the treatment has to be tailor-made depending upon the patient's age, distribution of the lesions, extent of lesions, type of lesions, and so many other factors, comorbidities, and many other things. Please do remember, this is for our younger colleagues and residents, that patients do not follow book, and treatment response does not follow any guidelines, Cochrane recommendation, US FDA approval, etc., etc. I do a lot of counseling that is very important of the parents and patients. Why I say parents? Because 60% of the atopic dermatitis, they start for the first time below 2 years of age, 80% below 5 years of age, and 90% below 18 years of age. So by and large, atopic dermatitis is a disease of the pediatric age group. This is very important in practice. Patients want to see result and they are least bothered about your knowledge, degrees, research, name and fame. खुजली कम हुआ क्या नहीं, eczema कम हुआ क्या नहीं, this is exactly what they will ask and come and ask you. Then if you say that leukotriene 4 is not working, they are going to go to another doctor after bashing you. So please do remember that. I try to make a balance between reality, giving them positivity as much as possible. I never say any negative things like it is incurable, blah, 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 all these things. I give them a proper information. I try to inject as far as positivity as possible, but try to make a balance. I don't give unnecessary rosy picture that it is going to disappear in 5 months' time or 1 year time, because I know it is not going to. Rather, I tell them that your child is in for a long drawn battle. You should be ready for next 5, 6, 7 or even 10 years. And maybe after a few years, I'll be able to tell you that how your child will respond further. And last is not most important, while taking care of my patient's skin, I don't forget about saving my own skin, particularly these days of MLC cases. So I never tell or commit or write something in the prescription which can land me into trouble. After saying all these things, let me come to a very important aspect of management of atopic dermatitis is the comorbidities. We must remember that unlike many other chronic skin diseases, atopic dermatitis is a disease which is, first of all, it is a disease of pediatric age group, and second, it is associated with a lot of comorbidities like psoriasis. That's why nowadays atopic dermatitis is considered as a systemic disease like psoriasis or systemic syndrome. Not only allergic comorbidities, So comorbidities are divided into allergic and non-allergic comorbidities. Apart from that, like obesity is also a comorbidity of atopic dermatitis, like psoriasis. Apart from that, most important period, just try to think that atopic dermatitis, particularly moderate and moderately severe atopic dermatitis, attacks a child when the child's education, development of, psychological development, physical development, social development, social skill acquisition, all these things are grossly jeopardized. Everything goes for a toss. Not only the child, the entire family suffers. If the child is scratching throughout night, how can the parents sleep? And nowadays, most of the parents are working. Next day, they have to go to their office. So restoring the disease at the earliest possible time and restoring the quality of life is of paramount importance. So this is the picture of atopic dermatitis in India. Since I shall be talking about how do I manage atopic dermatitis, I have tried to incorporate, most of the references from Indian scenario. Compared to atopic dermatitis in the West, what you all are used to be aware about from the Western books and journals. In our skin, the atopic dermatitis is different to a great extent. If I say it is totally different, it will be blowing the things out of proportion, but it is fact that it is different in a great extent. We see the classical atopic dermatitis, what you are used to see in the Western books, or what we have also read during our postgraduate career, is approximately seen in 30% of the cases. Rest 70% are minor forms, like juvenile plantar dermatitis, infra-retroauricular fissuring, atopic cheilitis, atopic vulvovaginitis, atopic penoscrotal dermatitis, and this is very important to label them as atopic dermatitis. In my prescription, I write JPD bracket AD variant, because the moment I write AD variant, it gives a lots of signal. It makes a world of difference in my approach to the patient. I tell the parents that, look, this is not something which is going to disappear in 4, 5, 6 months. It may take 5, 6 years. And the moment it is told to the parents, their unrealistic expectation disappears, which they have not earlier heard. They said, Doctor साहब पहले तो हमें तो नहीं बोला था ऐसा. Doctor ने बोला 2-3 महीने में चला जाएगा. So they saw themselves that it is not disappearing in 2-3 months. Forget about 2-3 months. In 2-3 years also it is not disappearing. So on the very first day you must tell that this is a chronic disease with remissions and relapse, and you have to be prepared for a very long drawn battle. Your patience and perseverance is of paramount importance. And when we follow up these patients, I have been following up these patients over last 20-25 years, I see those minor forms of atopic dermatitis or localized atopic dermatitis over next few months to few years, they start throwing more and more lesions, and that become a full-blown atopic dermatitis after a few years, a significant percentage of these patients, right? So if you do not have not told that to the parents on the first day, the parents will come after few years, after few months and challenge you, doctor, you didn't tell, aapka treatment se to badh gaya. With your treatment, it has spread all over your body. So it is better to tell them that this is the natural disease process and this is what may happen to your child, and that is a very important part of the counseling, and that's why I said at the very beginning, at the first slide of mine, I do a lot of counseling of the parents. It is very important to identify and diagnose them, as I told you, as atopic dermatitis, rather than just labeling it as a juvenile plantar dermatitis. Now this is again a very common thing which is not known to the Western world. It is a tropical phenomena, tropical countries phenomena, which we see quite often in our country. During extreme heat, the temperature soars up to 80 to 95 degrees. And humidity, 30 to 45 degree and humidity 80 to 95 degrees. I think it is same in Mumbai as well as in Calcutta, both the coastal regions.
And where we see miliaria formation with papillofascicular, which are very itchy. And in the just previous discussion, there was discussion about cholinergic pruritus, where Dr. Kiran said very rightly that during October, you see, when they go out in the sun, they start itching along with the, sweating and perspiration. Same thing happens here. Miliaria ruptures and form eczematization, and that eczema is known as miliarial eczema. It is not mentioned anywhere in the Western textbook, but I am sure in the next edition of the Rook's textbook of dermatology or Fitzpatrick's books, it is going to come up. So this is miliarial eczema. And if this picture is given to anyone who has not dealt with, tropical climate patients or tropical patients, obviously the person will make a diagnosis of atopic dermatitis, infantile variety of atopic dermatitis with involvement of face. But in our country, most of our dermatologist colleagues will diagnose it as a miliarial dermatitis, because he has seen the other parts of the body, he has taken the history, he has seen the boy is perspiring like anything. Something which is very important, which I have been seeing, and this is the part of my study which is ongoing in our Institute of Child Health, that a significant percentage of miliarial eczema later on gets converted to atopic dermatitis. Just like infantile seborrheic dermatitis, 33% they get converted to atopic dermatitis. This probably will publish after next few years. And this is already been established in the literature. The subclinical miliaria is a manifestation or formicrusty of atopic dermatitis. Some important do's and don'ts about atopic dermatitis skin. This is, published in a very, nicely written article from the Skin Allergy Society. And this is very well quoted article, I must say. Well quoted means I have seen many international, stalwarts in atopic dermatitis, they quote this article because this is the evidence-based review of, management of atopic dermatitis. So we all know that avoidance of irritants, avoidance of woolens, animal danders, use of cotton clothes are very, very important. Use of oils. I advise my, patients to use coconut oil mostly, particularly during the winter. Even they can apply during the summer. What I tell them, apply coconut oil all over the body, those who have got a dry skin. And over the flexures and the folds, you apply soap during bath. So after bath, you need not apply moisturizer, but at night you apply moisturizer. I shall come to that in a short while from now. And I give them 2 soap holidays. That means these children are very fond of, applying soap all over the body just like their parents. So give them, that satisfaction. They are very satisfied. And the moment they are satisfied, their atopic dermatitis will also be under control, because stress is a very important factor to aggravate atopic dermatitis. Use of moisturizer has to be very judicious. We should not apply moisturizer like in the Western countries, moisturizer paint. It is not required. I give moisturizer over the localized eczematous areas after applying steroid, then moisturizer or moisturizer followed by steroid, and in the surrounding area, not moisturizer all over the body. So this is very important, and nowadays I have observed that moisturizer, many children, because of the improved socioeconomic status of our country over last 10 years, many semi-urban or rural children also nowadays sleep under air conditioner. I ask the parents, and invariably the answer is yes. Do your child sleeps at night under air conditioner? Yes, doctor. So then you must apply, yes, doctor, the child gets up at night and starts scratching and skin becomes very dry. Apply moisturizer. That is a very important and useful practical tip. So some of the environmental agents which cause dry skin is hot water. We always say that use lukewarm water for giving bath. The parents, they have got a very peculiar psychology. They overdo for something which is not to be done, and they underdo for something which is to be done. You give a dose of antihistamines or antibiotic, they will ask the pharmacist, you have given thrice a day, they will give twice. Pharmacist will, doctor sahab to zyada de diya, thoda kam do. So they will give twice a day, augmentin instead of thrice a day. And while you say, tell them you use lukewarm water, they will use hot water और अच्छा result मिलेगा, right? डॉक्टर साहब तो lukewarm water बोला, हम तो hot water देते हैं और अच्छा result मिलने के लिए. So as a result, skin becomes more dry, right? And detergent is equally something which is detrimental to the atopic skin, which is very dry skin and skin full of abrasion actually. That's why synthetics and all these, nylons and other things have to be avoided. As far as possible, cotton clothes, I ask them to wear, or semi-cotton. Pollution aggravates atopic dermatitis. I make it very clear to the parents that look, this polluted environment will aggravate the atopic, the skin. Not only that, the child may develop sneezing because of allergic rhinitis. Many of these children have coexistent allergic rhinitis or have bronchial asthma a little bit later. Other chemicals and air conditioning is something which I have already told you. For mild atopic dermatitis like this, application of topical steroid, I prefer either mometasone or fluticasone to be applied, and this is fingertip unit. All of you know that what is the measurement of fingertip unit. The question is, do I follow it in my practice? Answer is no. It is not required. We know how much amount is required by and large. After a few years of practice, everybody knows. So for mild dermatitis, I tell them over sensitive area or in small children to use hydrocortisone acetate, or if it is not available, Dezonite for 2 to 3 weeks. Moderate dermatitis, few patches, localized patches, fluticasone or mometasone for maximum 3 weeks. Lichenified lesion over the extremities, you can advise even clobetasol propionate, but not more than 2 weeks at a stretch. This is a very important table to show the type of dermatosis and the potency of the topical steroid to be used and the location of the dermatosis. In the same child, the eczema over the face or over the perigenital area, you are supposed to apply hydrocortisone or maximum Dezonite, not mometasone or fluticasone. But over the extremities, over the trunk, you can apply mometasone or fluticasone safely, but for 2 to 3 weeks time. So in the same child, lichenified lesions over the palms, soles or over the extremities, you can apply clobetasol propionate. So this table actually depicts that what are the different variables in choosing a steroid molecule for treating atopic dermatitis children. Now often, this is being asked by our pediatrician colleagues mostly and physician colleagues that can we use combination of steroid and antibiotic? And we, in a tone of humiliation, is there is no need of doing like that. Honestly speaking, you touch your heart and say, do you do it? Always? No. We write steroid antibiotic combination. So what is why is this hypocrisy of admitting that? Steroid antibiotic combination is definitely needed for certain areas when there is localized eczema around the nares, external auditory meatus. Nothing works better than a steroid and antibiotic combination. I am not talking about 3 combinations. It is a simple steroid and simple antibiotic combinations. There are few in the market for limited period of time, 1 to 2 weeks time. But they really works better than only steroid. Like this. Here you have to apply a steroid antibiotic combination for maximum 2 weeks. Don't continue beyond that. After that, continue with moisturizers and give antihistamines for itching. However, if the infection is very extensive, here you give oral antibiotic, no question of steroid antibiotic combination. In fact, you avoid steroid application for at least 2 to 3 weeks. Just give moisturizers, give oral antibiotic or needed, if it is needed, if the child has features of toxicity, you give parenteral antibiotic also. A question often been asked by my colleagues, junior colleagues and physicians or pediatricians, because I work in a child hospital, that some of the atopic dermatitis eczema, they are steroid resistant. I tell them, see, the concept of steroid resistant eczema is just like smoke without fire. That there is a smoke, but there is no fire. It is absurd. It is ridiculous. It can never happen. No, there is no eczema on this earth which does not respond to steroid. Next question they ask, then why some of the eczema do not respond to steroid? I then show them this slide. Because of 4 reasons. One is non-compliance, one is under-treatment, one is sudden reduction of potency of steroid, one is sudden stoppage of topical steroid, and a rare variant is a steroid hypersensitivity, which is actually very rare. Now, the question is steroid abuse. We must remember, for extensive dermatitis, please don't give a steroid paint all over the body. Better you give short course of oral steroid, and that is recommended from International Eczema Council. We have published in British Journal in 2019, role of oral steroid short course in the treatment of atopic dermatitis, both in adults as well as children. It is well established, well documented. But if you give extensive topical steroid, like a steroid paint, there will be unmonitored absorption of the steroid in the system. If you are giving orally, you know you are giving 10 milligram of prednisolone, you know that how much it is going into the system. You have got a calculation. You don't know the serum level of steroid. Here you do not know how much is absorbed in from the skin. And as a result of that, the HPA axis goes for a toss. And a 6-month-old baby with infantile seborrheic dermatitis in whom steroid painting was done all over body with fluticasone or mometasone, I don't remember which molecule, and you can see the baby has developed iatrogenic Cushing. This is just one baby I am showing. I have at least 15 to 18 babies whom I have seen the same phenomena occurring. So never apply steroid over extensive area. Better you give oral steroid. And another thing you please do, please let the parents know from your mouth that this is steroid molecule, not the pharmacist's mouth or friend's mouth or his or her neighbor's mouth. You tell this is steroid I am giving, this is needed for your child. If you like it, you get treated by me, otherwise you take the child to another doctor. I am not going to treat your child. Because I do not know anything else beyond this. If he says, he will obviously ask, doctor, do you know anything else other than steroid? I said, I do not know. Jairam ji ki, ab aur kisi ke paas chale jao. Then they say, okay, I will listen to you only. Now, how do you use topical tacrolimus? Topical tacrolimus has come as a rescue for steroid phobia. Historically, it is very interesting to note that first article on steroid phobia came in British Journal of Dermatology in the year 2000. And topical tacrolimus first was published, US FDA approved in the same year 2000. So as if because of steroid phobia, topical tacrolimus found inroads into the mind of the people. And the people, many patients, they come and say, doctor, don't give me steroid. I say, okay, I am not giving you steroid, I am giving something which is not steroid. And that is topical calcineurin inhibitors, mostly tacrolimus. So what you have to do, you have to plan tapering of the steroid gradually over 3 to 4 weeks time and introduce topical tacrolimus. Initially you give steroid for, suppose you are giving daily, you make it alternate days steroid, alternate days tacrolimus for 2 weeks. Then next 2 weeks you give 2 days steroid and 5 days tacrolimus. In the process, within 6 to 8 weeks, you completely stop steroid and just keep the patient on tacrolimus. And please let me remind you, it is 0.1% which is useful, not 0.03%. And as if we could foresee that, we published the first study on topical tacrolimus in India way back in 1998. In fact, that time it has not yet been approved by US FDA. And these molecules were actually original molecules of Protopic by Fujisawa. Some of my NRI patients purchased it for their children. That's why small sample size, 15 patients only. The article was written much later because I didn't find someone like Abhishek to do the study and write fatafat. So it took time. So whenever we see very severe atopic dermatitis like this, we have to recourse to immunosuppressive therapy, like oral steroid. I am coming to that in a short while from now. Very important question before that I must answer. Do I advise IG in all patients of atopic dermatitis? No. I advise IG only for moderately severe and severe patients of atopic dermatitis. What is the reason behind it? Very mild atopic dermatitis, you advise IG. Probably you will be inviting trouble for yourself because the parents will come dancing in your clinic. Doctor Saab, IG is showing more than 2000 and my child has got only 2-3 patches. Why it is showing you? Then you explain to him for 1 hour, he is not convinced. And after 1 month you give treatment, those eczema have disappeared and he has come. You have not asked for, I see many a times I have not asked for the repeat IG, I never do that. When initial IG is very high, I tell it will take 6-7 months time, then I will repeat. But they themselves will do, applying their own brain, and will come with the report of from 2400, it has further increased to 2600. Doctor sahab, wo to aur badh gaya hai. So never do this. For milder disease, it is not required. IG does not guide in any way. For moderately severe or severe atopic dermatitis, yes, to a great extent there is correlation. And we have studied this, and this article of ours, I am very happy to share with you. It's one of the most well quoted article on severity and IG parameter. This is much more quoted than many European workers, legends in atopic dermatitis. I was very surprised to see it, and that gave me a big kick that its citation index is quite high. Now, systemic therapy for atopic dermatitis, I use oral antibiotics, corticosteroids, cyclosporin and methotrexate. For all practical purpose, I use these 4. Diet restriction and elimination diet only for moderately severe or severe atopic dermatitis when I am getting history from the mother, that with this it gets aggravated. What I do, I don't go for specific IG test, that has got no value. I ask the mother to tell what are the food items she has noticed when the child takes. Either the eczema aggravates or new maculopapular rash develops, or the child develops diarrhea or bronchospasm. In fact, skin manifestation is much less as compared to diarrhea and bronchospasm. They are more common. So when the mother says this, I tell that you give this one item, wait for 3 days, you see if there is no aggravation or no diarrhea, no bronchospasm, again give a gap of 3 days, again give the same item. Like these 4 items, it takes maximum 4 months time. This is called oral food challenge test, which you can do in your clinic. It does not need a very big setup of big premier institute to do that. Double-blind, placebo-controlled oral food challenge. And this is not my saying, this is the saying of the father of food and atopic dermatitis from Mount Sinai Institute, Hugh Sampson. He has said this is what you can do in your clinic, in your practice. Maximum 4 months it takes. For that you have to do some amount of counseling, of course. And another thing, these are the food items which we found in our study. This was part of one of our students' thesis actually. And subsequently we wrote an article which is also again well quoted article, me and Sahana Srinivas in Indian Journal of Dermatology 2016. These are the food items which you can see on the screen, which are by and large responsible. Many a times parents will say, doctor, my child has lactose intolerance, my pediatrician said. You have to make it very clearly, look, lactose intolerance has got nothing to do with the milk allergy. It is a different kind of thing, an enzyme deficiency. Now the question comes, $1 million questions, that when and why we need newer therapies. We need newer therapies like biologics and others because even with immunosuppressives like cyclosporin, methotrexate, 5 to 10% of the patients nowadays, they do not respond to immunosuppressive. Repeated courses of cyclosporine I have given, the disease is not brought under control. And many a times I have seen the child has been brought the other day only, just before coming over here, day before yesterday, I saw a child has been brought from Assam. There is a place called Bongaigaon, and he has been referred to me. I get many referred atopic dermatitis patients from many parts of the country, in fact outside the country also. Say that child has got not 1 millimeter body left which is not affected by atopic dermatitis, almost atopic erythroderma. And this child, I told them that he will need dupilumab, and the parents immediately agreed. So upfront treatment with biologics is also very, very important in some patients. Crisaborole, I don't have much good experience with crisaborole. Moreover, it is a very costly molecule. Apremilast I have tried in some patients. The result is kind of so you can say, not very exciting. It takes longer time to exert its actions. It's not very consistent result. But the real game changer in the treatment of atopic dermatitis is dupilumab. Friends, let me tell you very clearly over here. And this is not only my experience, this is the experience. Recently I was in EADV, the whole session for 4 hours was on atopic dermatitis recent management, and the other speakers were, all the chapter writers in textbook. So everybody felt that dupilumab is the best so far as the treatment and bringing the quality of life of atopic dermatitis is concerned. It is not an immunosuppression, so that's why you don't need to do repeated blood tests. You please do remember, while taking into account about the cost of this molecule, which is exorbitantly high, approximately 52,000 for a 300 milligram of prefilled syringe. But you don't have to do repeated blood tests like immunosuppressives every 3 weeks, every 4 weekly CBC, LFT, urea, creatinine, nothing. So that investigation cost per month is more than 10,000. So that you are saving while giving dupilumab. Please keep that also in mind. Recently we have, this has been published just few days ago. In fact, it has been published. I am happy that Dr. Abhishek is there. Dr. Abhishek and Dr. Maitri Panda are the two persons who helped me, in participating in this European trial of effect of systemic immunomodulatory treatments on COVID-19 outcomes in patients of atopic dermatitis. Results from the global secure AD registry. This is a huge registry with a huge data, very interesting observations. And here I must say, single most important thing is that it was found that from this registry that dupilumab is the only drug which can be given with severe atopic dermatitis, even the patient has active COVID. It is the only drug which can be given to someone with severe atopic dermatitis who is contemplating vaccination without any interruption. Continue dupilumab, don't stop it. Previous concept was stop it for 2 weeks, give a gap of 2 weeks, again give. That concept is no longer tenable after this registry has been published. I think this is going to change the concept about the COVID and atopic dermatitis. So this is how dupilumab looks like when it is prefilled syringe. The piston is inside and the metallic coiled ring is elongated. When it goes subcutaneously, the piston comes out and the metallic coil inside that gets shortened and compact. This is the first study on dupilumab, me, Abhishek and Sahana published in Indian Journal of Dermatology, 25 patients, and the result was very exciting. In fact, it really brings the quality of life for those children whose and their parents' lives are tormented by severe atopic dermatitis. Moreover, we found another very interesting observation that such disfiguring hyperpigmentation and lichenification, for the reason the child was not allowed to attend school, no peers wanted to play with the child. for his appearance, that could be to a great extent changed by dupilumab, and I was very surprised when I presented the same data over last couple of months in different parts of the world. Many people treating with skin of color patients of atopic dermatitis, both in Europe, America, as well as in Kuwait, they said the same thing. They are also observing this hyperpigmentation and lichenification is only taken care by one drug, that is dupilumab. So it has probably something extra than other drugs. But I think we need to have experience with large number of patients. So this is the color change you can see. Last 2-3 slides about JAK inhibitors. All of you know about the names which are used for atopic dermatitis. You can read it out on the screen. Currently available JAK inhibitors in India mostly for the rheumatologic purpose, but nowadays the companies, they know that dermatologists are also using it, so they are visiting our clinic. We have also JAK inhibitors, so they know what are the conditions where we use for alopecia areata, for atopic dermatitis and psoriasis. I am using JAK inhibitors, oral tofacitinib also, though it is not yet US FDA approved. Abhishek is also using. Probably we will come up with a publication in future. Something which Dr. Murli very nicely elaborated, giving the detailed pathomechanism of leaky gut, leaky skin syndrome. So hence I am not going into detail of that. The probiotic has got a definitive role, though the study is very limited, as he has very rightly pointed out. But please do remember that all probiotics are not useful. Many of you are maybe under the impression, because the pharmaceutical company will come and tell you, doctor, this is probiotic, this is going to work in atopic dermatitis. Please do remember that enterogermina does not work. That is Bacillus clausii. And there is a study carried out by my alma mater institute, PGI Chandigarh, by Dr. Sanjeev Handa and Dr. Rahul Mahajan, that lack of efficacy of Bacillus clausii in atopic dermatitis. And I told them, I really salute your guts. I really salute the guts of the editor who published it. Because no negative study is published. This is the international policy actually. You will hardly find any negative studies, because they are all pharma-sponsored studies actually. So no pharma will allow to publish any negative studies of their molecule. So this is the package and this is the dosage of Allergy. Out of all the probiotics, Lactobacillus rhamnosus GG is maximally trial, maximum efficacy has been found, and I have got a very good experience of using Allergy. This is what I do in my practice. Many a times patients who are on cyclosporin for quite some time and they cannot afford any further, or because of some complications, because of leukopenia, I cannot give, or thrombocytopenia, I cannot continue with cyclosporin, or creatinine level high, I cannot give, I switch over to probiotic. And I have seen that same kind of result remains, maintenance remains, efficacy remains. Patients on immunosuppressive, other immunosuppressive, during flare I subsequently use probiotic and they show good result. In some patients, even upfront probiotic I have used, I have got very good result with that. And many a times patients are also happy that with this drug, this is, first of all, it is written, it is a nutritional product, not a drug. They are very happy. The psychology is something which is very much pampered. Second thing, they don't have to do repeated blood test, right? So probiotic has got a good future, and we have to see what happens in next 5 years. The last slide is the impact of atopic dermatitis on the patients and families. Some of it I have already shared with you, that different types of anxiety, depression, frustration in the children, social rejection, feeling of shame in the child. Many children I have seen, they don't want to go to any in some family function with the parents because of their disfiguring look, because our very inquisitive relatives and friends, they ask what is happening to your child, as if the parents are not bothered about their child. All headache is there for another's child. So this is the Indian psyche typically. I am sorry to say that. Stress and low esteem in the mother. This happens, bound to happen. I have seen it happening in thousands of mothers. So all these things can only be controlled by a thorough counseling, which I do very thoroughly. I spend at least 25 minutes time to my patients of atopic dermatitis. It has happened, I'll take one more minute. It has happened so many times that 3-4 of my patients waiting in my clinic, either they go to nowadays they go to the reception, they don't have guts to come to me. But 20 years ago, they used to barge into my room and saying, "Doctor, you are giving so much of time." I said, "I'll give 45 minutes time." I have actually given 10 minutes time just now. I said, "I'll give 45 minutes time. You please get the full refund from my reception and get lost from here. Go to another doctor." I don't say get lost, go to another doctor. Again, Jairam ji ki. Then they stay back. At times you have to be rude to someone to do good to someone. So at times I am rude, at times I am sweet. Thank you very much.
Thank you, Dr. Sandipan. It's excellent. And you had given enough time to us and counseled us well, and everyone will follow your guidelines. Thank you very much.
Ashok. Thank you very much, Ashok bhai.
Anyway, for panel discussion, we call the moderator here, and all panelists, of course, moderator would introduce. Can I call upon moderator, doctor?
सर बाजू
Thank you, everyone. I'll skip the elaborate. All our panelists already and please forgive me for my bad voice. My name is Abhishek, but nowadays I'm sounding like Amitabh Bachchan. It's not the true thing. Everyone knows you, ma'am. Please come. I'll skip the elaborate decoration of your, decorated career. Please come in here. Dr. Aarti, please come in, don't waste time. We are running late, so I'll make it short. Already most of the part of our panel discussion be taken care by Sandipan's lecture, his personal idea about treating. I agree to sir that guidelines are there, though we have written a guidelines are there to help us to reduce our mistakes, but it's not a doctrine. So you can sometimes deviate, especially in country like India where insurance coverage is low, and that's why a lot of people cannot afford drugs like Zelzans or Dupilumab, all those things. So and those people, we need to use some innovations, and that's when we need to deviate from our guidelines also. Can I get my slides, please? Not here. Panel discussion. So we have already discussed a lot of part of the things. So we come to the first case, and in a case of mild atopic dermatitis, we all talked about our Indian guidelines, which we published a couple of years back. It has been already cited about 70 or 80 times, so it's quite highly cited. This is our guidelines. Please try to follow as much as possible. However, as doctor has already stated that we can't deviate at certain point of time, especially now we have Dupilumab, we have JAK inhibitors, so possibly we are using azathioprine and mycophenolate much less commonly than we used to be in past. But I'll come to one thing, Belashamam. Because sir has already spoken about food allergies, and food allergies in India is widely blamed. So how do you counsel your patients?
So I always tell them not to associate everything what the child is eating with the eczema. So what are the known allergens? I brief them about them, and as Dr. Sandeepan already mentioned in his talk, that you observe whether it gets aggravated after consumption of that specific ingredient. Then and then you can attribute to that. But there is no blanket ban on so many things for a child. So I just counsel them, these are the possible allergens as far as food is concerned. I do brief them about them, but not that everything the child has to avoid. And many times I have seen patients are put on gluten-free diet, even for atopic eczema, especially when they visit from America and Europe. I have seen Indian children visiting us and they all are avoiding wheat. Why? This is the concept there, gluten-free diet. So I just explain them, and when they are around us, say for 4 weeks or 8 weeks, I tell them to eat wheat and come back to me. And I have seen no flare of atopic eczema when they are put on gluten-free diet by their Western, dermatologist or maybe their medical officers or whatever. So I just tell them not to avoid things.
So no blanket restriction on food, possibly maintenance of a food diary is good. However, in Calcutta, everybody loves a elaborate food taste. I don't know about other part of India, but in Calcutta, every one of my patient comes with already a food test done. Murli sir, that happens in Chennai also?
I think it happens everywhere. That's the problem.
So how do you counsel those
as far
patients?
as these food allergy tests are concerned, we should remember that they have a good negative predictive value. Because when you look at the test reports, you will find about 50 positives and about 90 negatives. Now, if a patient tells you that, say for example, nuts produce an allergy or worsen the atopic dermatitis, a negative test is more helpful. But once again, it has to be correlated with the history. Normally, I do not encourage doing these Fardiatop assays or ELISpot assays for any of my patients. And if I may take an extra half a minute of your time, when you talk about food allergy, I think when we talk about adults who develop atopic dermatitis, one thing which is very important is to tell them to avoid alcohol. That is the thing what I tell my adults, because there is an enzyme in the stomach which is deactivated by alcohol. Once the enzyme is deactivated, then pseudo-allergens and allergens in the food which normally don't produce a problem are going to get absorbed very fast. And I have personally seen this in a couple of my patients with shrimp, so-called shrimp allergy. Whenever they took it along with alcohol, it worsened. You take it without alcohol, nothing happens.
Very true, sir, but a lot of our North Indian patients will not like your idea that I can talking about personal hygiene, to bathe or not to bathe is a big deal. They talk about, I'll not go to that because Sandeepan has already spoken about that. Dr. Aarti, I'll come to you. Now, a lot of people ask for, these Syndet body cleansers and Syndet soaps. Do you recommend to your patient those things, and what are the tips about personal hygiene your patient you always counsel?
I generally advise Syndet to my patient which have a low pH, acidic pH or a neutral pH, and the cleansing agent, it should also be hypoallergenic, it should be non-irritating, and it should not contain any fragrance. And regarding cosmetic products, I advise to use products which do not contain fragrance, formaldehyde, lanolin or preservatives. So this is what I advise.
Very true. Now, clothing in Western population, there is a suggestion that they use silver coated clothes for atopic dermatitis, and I don't think it's quite practical unless they are kind of from some Rajput kingdom. So how do you counsel your patient for choosing a right clothes in India, keeping in mind many of our patients are actually from places where there's a very hot and humid summer?
Loose and cotton cloths. They should not be wearing tight cloths. They should be wearing loose clothes, one size higher, and cotton cloths, preferably. But if they are in Kashmir, naturally they'll have to wear woolens. So And under the cotton cloth, they can put on their woolen cloths.
So natural fibers like smooth cotton or smooth silks can be possibly owned. And if you have to wear some woolen clothes, it should be on top of the cotton clothes. Even if you are buying the fast clothes, it's always better to wash it couple of times before you should start wearing, because there can be less chances of allergy dermatitis on those patients.
Because it contains formaldehyde.
Please, Sandeep.
Those new cloths have formaldehyde, and
So-
that can irritate the skin and give rise
Also,
to
this
exacerbation.
wrinkle-free stuff,
Yeah,
all
yeah.
other, those things can cause contact eczema in this
Exactly.
patient. Sandeep, please.
Actually, the concept of silver coated clothes came from Australian dermatologists who are working in atopic dermatitis. Later on, it was evaluated all over the world, and in our International Eczema Council, after thorough research, we have seen that the silver coated clothes, actually why it was basically recommended, because it prevents the Staph aureus colonization of the skin. So if we do a good hygiene, maintain a good hygiene and give proper bathing, that will take care of it. There is no need, because
Unless
this is
you are born with a silver spoon, I guess.
Yes.
You have already spoken, Sullivan, I'm coming to you only. You have spoken about moisturizer in details. I'm not going into in depth of that, but there are so many emphasis on prescription emollient devices. How do you recommend that to a patient, and at what scenario?
See, prescription emollient devices is basically moisturizer along with other substances, and it is recommended only for those patients who have read from the net that prescription emollient devices works better than the any ordinary moisturizers. So to satisfy their anxiety, to address their anxiety. Otherwise, prescription emollient devices is basically a fascinating term. It is no different from a good moisturizer. For mild dermatitis, just white soft paraffin, liquid paraffin is fair enough. For moderately severe or severe, ceramide containing moisturizers.
But I would like to add here, prescription emollient devices, they have the heavy moisturizers, and throughout the year, 9 months, we have a hot and humid climate. Our patients perspire more after applying the prescription emollient devices, and that makes their eczema worse because it aggravates itching.
Absolutely true.
So they are not very useful in Indian context.
Absolutely true.
Even in Western context, meta-analysis has been done and didn't give any particular benefit of using prescription emollient devices over the normal moisturizers. We have to remember that it's expensive, so compliance is a big issue in Indian perspective, where patient has to pay from their own pockets. So all those things has to be kept in mind. However, in certain subset, if you think that this patient needs prescription emollient devices, and if this patient can afford it, it can be tried. It's nothing harmful, but you cannot give it to all our patients for sure. Now you have spoken already about in depth about topical corticosteroids, so I'm not going into details about that. Topical corticosteroids still remains a kind of cornerstone of our practice, but I'm coming to systemic corticosteroid, because this is something always gets abused in our country. So Murli sir, can you just tell us in brief how long, what steroid, and in what scenario we should be giving oral steroids in these patients?
I mean, generally, when I prescribe a systemic corticosteroid, I use only prednisolone. I try to use it for the shortest possible duration, because I'm using a systemic corticosteroid to combat an acute flare. I mean, you saw one picture of an acute flare which Dr. Sandeepan had shown. So I would prefer to use it only to control the acute flare, so that I can shift the patient on to something else after that. So if I can get away with 2 weeks to 3 weeks, I'm happy with it. And it is easier to taper off also.
Do you start another molecule by that time, so that like something like cyclosporine or maybe apremilast or something?
Now,
like that?
you see, if my patient is happy to use cyclosporine, I won't use a systemic corticosteroid. I'll just start him off on cyclosporine straight away. It's a much better alternative to systemic corticosteroids. But since the question was on systemic steroids, there are some patients who probably can't tolerate this. Most of the cyclosporine available in our country, you can't tolerate. There is severe GI intolerance. And but if they can't afford or tolerate, or there are other contraindications, you can use a short course of systemic corticosteroids. And I prefer prednisolone because it's easier to taper and wean them off.
Thank you, sir. Dr. Aarti, I'm coming to you, topical calcineurin inhibitor. Which topical calcineurin inhibitor you like? At what scenario? Do you start with topical calcineurin inhibitor? And at what strength? Which scenario you've been using? So can you just elaborate your use of
I generally
these
start
guys?
with topical corticosteroids, and then when I taper the topical corticosteroids, then I introduce tacrolimus, and I also don't use 0.03%. I prefer 0.1% of tacrolimus, and I am also not fond of famicrolimus, though it is recommended in less than 2 years of age and on areas like the perioral area, the periorbital area. So in those areas, it can be used.
So this is where I usually differ from Sandipanda, and Sandipanda doesn't believe too much on pimecrolimus, but I am a big user of pimecrolimus. Can anyone of you support me with the use of pimecrolimus, please?
Yeah, I find pimecrolimus very useful on the face and on the folds because this tacrolimus does produce a bit of irritation, and the atopic skin is already irritated. It takes time. The irritation happens because the barrier is defective. Tacrolimus, however, is a very good alternative and a very good drug to use because it also repairs the damaged barrier. But at least in the initial period, I would like to use pimecrolimus.
Especially if you use the originator molecule, then it always works. The problem is many Indian brands seems not to work in pimecrolimus.
Hot spots also, they're good drugs for maintenance therapy.
So all the flexural areas, all the sensitive areas,
Yeah.
face, all those areas you can use, especially hot, humid summer, because tacrolimus sometimes cause a lot of burning sensation. But ma'am, I'm coming to you. A lot of people these days go to Google and say, okay, long-term use of topical tacrolimus can lead to malignancies. How do you counsel those people?
So we have to counsel the patients because there is a black box warning for the topical calcineurin inhibitors which is prevailing from US FDA. So you have to brief, and the use should be intermittent rather than continuous. So it is always better to stop these drugs when the patient has achieved the maintenance.
I am sure other people have stories about that. Can anybody share?
No, I just want to share one thing. Once we had Dr. Lawrence Schackner coming down to Chennai, and we had a good part of 300 dermatologists listening to him. And he said that this whole thing about, of course, the American Association of Allergy and Clinical Clinical Immunology has already rubbished the black box warning. That has been done very clearly. But Schackner told us the background about how the black box warning came, because they fed mice with 19 to 30 times the dose of tacrolimus orally. It was not through topical.
And it was in a situation where there are other molecules have been shown to, can you just elaborate?
There is a story about black box warning. Let me share with you. I have found it after a lot of hard work and research, and I always share everywhere. I spoke in Lucknow also. Rofecoxib was a leading non-steroidal anti-inflammatory drugs being used by Merck worldwide, and it has already been marketed, and few $100 billion are already been profited by Merck. During post-exposure, treatment survey, it was found that it is causing in huge number of patients nephrotoxicity and bone marrow suppression, to the extent that US FDA was nabbed by President as well as the US Supreme Court, and US FDA was forced to ask Merck to stop using Rofecoxib and destroy all the Rofecoxib stock they had. So they ran into $1 million loss. That is the year 1999 to 2000. And unfortunately, US FDA, they had a burning of their face, they burned their face, and whatever was put on the table on the US FDA for approval, they put a black box warning without considering whether it is a topical or systemic. Bechara, unfortunately, tacrolimus, I mean calcineurin inhibitors was put on the table of US FDA in 1999 and 2000. So that's why they got
Very
this
true,
level of black.
Sandipanda. So it is kind of circumstantial. Moreover, the molecule came from Japan. So that is something we need to consider also. However, it's been 22 years we have been using this molecule left and right without any much of a problem, I guess.
Another thing, sorry, Abhishek reminded me, the regulatory bodies of Japan regarding drugs, it is, I have come to know from several of my colleagues all over the world, is much more stringent than any other regulatory bodies anywhere in the world.
So coming to the severe atopic dermatitis, we all has to use some form of immunosuppressive therapy, but unfortunately phototherapy is one part of the treatment which is often ignored in our country for whatever reason. Anybody has experience of maintaining atopic dermatitis with phototherapy, and then what kind of phototherapy you've been using?
For maintenance, once the acute flare is controlled with any of the systemic drugs, then you can maintain. But then the children have to attend to the schools. It is difficult for them to come to the facility for the phototherapy sessions.
Interestingly, when I was in National Skin Center, they used to use UVA1 therapy. Anybody in India have been using UVA1 therapy? I think pretty expensive, it's not there.
So we are using it for morphe, UVA1 therapy, not for at least atopic dermatitis.
Well, good, very nice.
But we don't use it for atopic dermatitis, we are using for morphe.
Okay. But you can try it because it's
Definitely, no, I'll try.
It has a lot of documentation of UVA1 therapy on eczema, so you can try it. Cyclosporine, Sandipanta has already spoken a lot, but couple of things I have to know. Step up or step down, Murli sir?
I do step down.
So you start with
4
high
milligram,
dose?
yes, I start with 3.5 or 4 milligram and then I step down rather than starting from 2.5.
Another thing I want to know from you, in case of pediatric use, we have to give syrup. So any particular precaution you tell your patient or other parents to maintain when you are giving syrup from cyclosporine?
So I just tell them to mix with lemon juice, putting a lot of sugar in it and then give. I use it about 2 years and above, not below 2 years and below. But probably even moisturizers and topical steroids are good for pediatric practice. So I don't use below 2 years of age. But I think for my patients, lemon juice works.
Sandipanta, I have been compiling your 430 patients data of cyclosporine given to pediatric age group, and I'm having a hell of a time. So you have not used it that much below 3 years. Any particular reason for that?
Reason being that as per universal immunization program as well as the immunization program by Indian Academy of Pediatrics, most of the immunization or vaccination is covered 80% approximately covered by 3 years of age. So since during cyclosporine therapy and after stoppage of cyclosporine therapy, to be on the safe side, for at least 1 month you cannot give any live vaccine. So that is the reason I am bit reserved in my approach of starting cyclosporine below 3 years of age. But that does not mean that I have not given. I have given cyclosporine to even 6 months of age baby also with extensive atopic dermatitis for few weeks only.
Very true. Another particular thing I usually tell my patient that cyclosporine syrups comes 100 milligram per milliliter. It's not per 5 milliliter. So there's a huge chance of risking if you write half TSF like the way we write syrups. So this is something you need to keep in mind. Use a Mantu syringe or insulin syringe if you don't have a cyclosporine syringe access because it can cause a huge lot of risks to our patients. Methotrexate, anybody has any idea how this molecule should be used in patients of atopic dermatitis and especially at what dose?
It should be 0.3 milligram per kilogram body weight if you want to use in pediatric practice.
In adults?
In adults,
50 milligram.
We use 7.5 and above weekly doses as we use in for psoriasis.
Can I talk?
Yeah, please.
I have shared with you, Abhishek, over phone that we have a collection of data of more than 360 patients of atopic dermatitis, both children and adults combined, on methotrexate. Dr. Raghubir Banerjee and Rajiv Malakat, they are writing this paper actually. So we have seen that those who cannot afford cyclosporine, something which is more interesting, we have observed it even 4 or 5 years ago also, because this is the data of over last 10 years, that some patients who do not respond to cyclosporine, they respond to methotrexate. This is what we observed, and now this is the concept which is being believed by most of our atopic dermatitis experts all over the world, and this has been discussed in International Eczema Council several times, that methotrexate in some patients who do not respond to cyclosporine, methotrexate is a good alternative.
Maybe it is single gene polymorphism or something to do with the enzymes?
Yes.
Dr. Arti, just want to know, because we have to give in our severe patient of atopic dermatitis, while we cannot give dupilumab, so cyclosporine, and intermittently we have to give methotrexate. Do you plan or give the patients plan in beforehand only that, I'll give about 3-4 months of cyclosporine and then I can change it to methotrexate? Do you plan like that?
Depending on the course of the disease and how the patient is responding, depending on that I decide.
So sometimes we can induce the remission with cyclosporine and maintain it with either phototherapy or methotrexate, given that in India a lot of people cannot afford dupilumab. Antibiotics we have already spoken about, so I'll not go into details, but this is a patient of adult atopic dermatitis, and this we are increasingly getting. So I want to know from you, what are the clinical features of adult atopic dermatitis? Because I think it's distinctly different from the childhood kind of atopic dermatitis.
No, we do get adults who have typical involvement of the popliteal fossa, cubital fossa, the dirty neck, and they do have a history of allergic rhinitis and conjunctivitis and family history of even a bronchiasma. Or they themselves have evolved the atopic march. So I have such subset of patients wherein there is no difficulty in diagnosing atopic dermatitis. But then there are so many other atypical forms of atopic dermatitis, especially in adults. Like you can have the hand eczema, even nipple eczema. So there are so many other variants which can be
prurigo nodularis.
Prurigo nodularis
Yes,
in adults.
No, I just want to say that as Dr. Bela said, we can see the typical variations, but one thing you should remember is that many patients present to you with erythroderma, and that is where you actually find the difficulty in finding that the patient was atopic and ended up with erythroderma. It takes time there to make a diagnosis.
When the patient come to you in the erythroderma phase, it's so difficult to know that.
It is very difficult. You are going to have to really work the patient up in great detail, and if you're lucky, you'll get a history, but most times you don't get a history.
Now, kind of quick fire. Apremilast, who are the takers?
Only for maintenance.
Hand eczema, atopic hand eczema?
I use it.
So that is something I find, because sometimes I fail to diagnose anyway my clinical diagnosis for. So whether it's a atopic hand dermatitis and or palmoplantar psoriasis, in both scenario somehow the apremilast works. So this is one JAK inhibitor. Now there are fantastic molecules got recently from 2020 to 2022. We have a lot of molecule got abrocitinib is coming to India, is already in the phase 3 trial. But at this moment we do not have ruxolitinib, anything else. We just have tofacitinib. So anybody has an experience of tofacitinib?
I am happy with tofacitinib. It's a good drug for recalcitrant eczema. I don't use it as first line of therapy, but recalcitrant eczema, especially above the age of 18, I prefer to use it above the age of 18. I find it's good and you can use it for long periods of time. It's not as dangerous a drug as people believe it to be.
It's JAK1, JAK3 inhibitor, so it doesn't have too much impact on the JAK2.
Can I comment? Just our studies, this thing, few lines. Tofacitinib is, regarding the safety profile of tofacitinib, I feel that these things are blown out of proportion, and it is very safe. I have used tofacitinib 5 milligram single dose in 5 years old child, who was not responding to cyclosporine or who cannot afford cyclosporine.
So this
with
is the
proper
data,
monitoring,
basically.
and there has been no adverse effect. Let me tell you very clearly, there is not one child, at least 25 to 30 children are under treatment with me with oral tofacitinib.
So we are publishing, on the process of publishing a 16 patients of tuberculosis. It's not a huge data, but we are finding good result with almost no side effect. We have found couple of patients with hypertriglyceridemia and couple of patients with six. No, I also have.
See, tofacitinib has got approval from US FDA for atopic dermatitis. So I really don't think we should worry too much about tofacitinib in atopic dermatitis.
Sir, I don't think it has got approval. Abrocitinib got, ruxolitinib got, sir. Only 3 molecules got approval. Ruxolitinib for topical, abrocitinib for oral. But tofacitinib hasn't got. Pfizer has sent it to US FDA. US FDA appreciated the efficacy but wanted longer safety data. So it's not yet approved in a sense.
I stand corrected.
Okay. However, it doesn't work on the JAK2, so it doesn't have too much of blood count decrease. So it's a quite safe drug in that sense. But I would love to know, anybody has an experience with Eucrisa, crisaborole? Anybody, any practical experience on Eucrisa?
I shared my experience is not good because there is a lot of burning sensation with Eucrisa. If with topical tacrolimus, in a grading of burning, you say it is 20%. With topical crisaborole, it is more than 60 to 70%. Invariably, it burns. And second thing, it is not a magical drug, and it is not worth buying a tube of 60 gram of Eucrisa as of now in India at a cost of 53,000. It is $711 US. You can calculate it in your calculator. What is the current rate of US dollar and what is the cost of it? So it is not worth. It is nothing magical. It is not an enigma.
Thank you for everyone. You already have shared your experience of dupilumab, so I'm not going into details. However, I have certain things to announce. That I'll announce that. Can I get the Pfizer slides? Next slides, please. So, Skin Allergy Society, along with Pfizer, could have come up with a patient information leaflet for atopic dermatitis. It's kind of a very comprehensive leaflet for our patients. So I'll just show you the sneak preview of that. Pfizer people who come into your clinic and give it in your details for your patients. I can give you one. Yeah, please. So this is the Pfizer initiative. We are from Skin Allergy Society. We are thankful to Pfizer for collaborating with us and getting this for Indian patients. We will try to get it every regional languages also. So it's all details about this atopic dermatitis, including the poem score the patient can maintain on their home. Thank you, Pfizer, for us. And with this, we'll stop the session and moving to the next session. Thank you, everybody. Murli sir has a point here.
I'm sorry to prolong this, but since we skimmed over biologicals, I think one very important thing we need to understand is that the cytokine, as of now, dupilumab seems to be working very well. But as with all biologics in all diseases in dermatology where we are using biologics and even in other conditions like oncology and all, we are going to have to combine this with biomarkers. And in atopic dermatitis, there is a lot of variation in the cytokine profile in different stages of the disease. So as we keep using these biologics in atopic dermatitis, we are bound to come up with the failure of the biologic. And therefore, it is important for us to just keep the perspective alive that we need a little bit more work on the biomarkers so that we can move towards personalized precision therapy. Thank you for giving me the extra time, Abhishek.
Thank you so much, faculty. That was a very informative and interactive session on atopic dermatitis. I would request Dr. Kiran Godse sir to please felicitate Dr. Ashok sir.
Birthday boy.
I would request Dr. Mullidhar sir. Dr. Sandeepan sir. Dr. Sandeepan sir. I would request Bella ma'am, please. Aarti ma'am, we would request your presence on the stage. And Abhishek sir, thank you so much for being such a wonderful moderator. That was an amazing second session. I would like to hand over the podium to Dr. Ami Bojani to take over for the third session. Thank you.
Good afternoon, everyone. Welcome to the third session that is on contact dermatitis. I would like to call upon Dr. Prashant Jadhav, who is consultant dermatologist and cosmetologist at Jalgaon since 25 years. I would like to call upon Dr. Harsh Timbadia, a senior consultant dermatologist who passed his MD from Grant Medical College, JJ Hospital in the year 1984.
Good afternoon, everyone. Since we all are suffering from acute exacerbation of chronic hypoglycemic syndrome, we'll try and make it as short as possible. The contact dermatitis plays a very important role in our practice, day-to-day practice, but the process is very tedious. A good thing is that we have Dr. Satish Pai, who is going to give us the tricks and tips on patch testing, by which we will be able to differentiate contact dermatitis, allergic contact dermatitis from irritant contact dermatitis. Dr. Sandeep Pai is the Professor of Dermatology, Department of Dermatology, Kasturba Medical College, Manipal. Over 100 publications he has. He was a president in Karnataka branch in 2019, Commonwealth Fellowship in Photodermatology 2008, Nine Wells Hospital. Dr. Sandeep.
Yeah, good afternoon. Thank you, chairpersons. At the outset, I would like to thank the organizers for giving me this opportunity to speak on patch testing. Now, our skin is exposed to an ever-increasing spectrum of chemical and biological products. As a result of this, the incidence of allergic contact dermatitis is increasing. Now, the dermatitis can occur on any part of the body as shown in this slide, and it depends on the causative allergen. Patch testing is a very useful diagnostic tool which can be utilized for solving the puzzle of contact dermatitis, in which etiology is obscure or management is problematic. Now, this study in 2007 showed a sensitization rate of 35.4% in women and 14.8% in men. Now, allergic contact dermatitis occurs only in a small percentage of sensitized individuals, and this incidence ranges from 1.7 to 6%. Now, what is patch testing? It's a bioassay, and it's the only tool to prove sensitization to a substance causing allergic contact dermatitis. Patch testing is artificial. It does not duplicate clinical exposure. In clinical exposure, sweating, maceration, and multiple applications play a very important role in initiating the dermatitis. The patches are applied for a fixed duration of time, and the concentration of the allergen in the patches are defined. Patch testing is a better method than clinical trial and error. Now, what is the role of patch testing in dermatitis? One is to identify the triggering or aggravating factors. By knowing the triggering factors, we can give proper advice to our patients as to what to avoid and how to avoid, and this can bring down the morbidity and increase the quality of life of our patients. Now, what is an ideal patch test? The patch test should indicate contact sensitization. There should be no false positive reactions. The allergens in the patches should be pure and in the right concentration. There should be a very low risk of active sensitization. Minimum irritant reaction. The patches should be stable, easy to apply, and easy to read. Now, what are the indications? One, it's indicated in all eczematous disorders where contact allergy is suspected. Two, in eczematous disorders not responding to the usual line of treatment. In chronic hand and foot dermatitis. In persistent or intermittent eczema of the face, eyelids, ears, perineum, and in varicose eczemas. Are there any contraindications? Yeah, presence of active dermatitis or presence of dermatitis at the site of application of the patches. We should not conduct patch testing. Patients who have immunodeficiency or are having autoimmune diseases, patients on immunosuppressive drugs, and during pregnancy and lactation. Now, what is the rationale of patch testing? It's to elicit an immune response by challenging already sensitized person to defined amounts of allergen and then assessing the degree of response. This is the patch test unit. We have the fin chambers. The fin chambers are nothing but tough aluminum chambers which has got a diameter of 8 mm and depth of 0.5 mm. You can see that these chambers are attached to microporous tape which is stuck to plastic films. This is the test material which we use in our department. It's Indian standard series obtained from Chemotechnic Diagnostics, Sweden. It's available in 5 ml syringes. And these are the 25 antigens, and you can add additional allergens if required. Now, during patch testing, we should avoid bath or shower, exercise, activities that are likely to dislodge the patches. Now, certain medications like systemic steroids for 2 to 4 weeks, topical steroids over the area where we are applying the patches for a week, and also topical immunomodulators. Now, let's see how the patch testing is done. So, these are the two series which we use in our department, that is photo patch test series and the Indian standard series. It has to be stored between 2 to 8 degrees centigrade. So, having a refrigerator is a must. And this is how the patches are removed. The micropore tape is stripped off from the plastic sheet. And you can see that there are 26 chambers. And start placing the allergens from the top right corner. So this will be number 1, and then go downwards and place the antigens. So when we place the antigens, we should apply about 2 to 3 millimeter of antigen at the center of the chamber. See that it does not contaminate the adjacent chamber. If the allergen is a liquid, you can put a filter paper in the chamber and then add a drop of the allergen. This is formaldehyde. It's placed at the center of the chamber. So in our department, we shave the area just before applying the patches. Ideally, it's better to shave 2 to 3 days. To avoid one more visit to the hospital, we shave just before applying the patches. And this is how the patches are placed. You can see that the plastic film, which is still attached to the microporous tape, will help us to place the patches on the back. So first stick the lower part and then the upper part. Give firm pressure to remove air pockets and also to see that the patches are in place. You can also use transport tape at the edges to keep the micropore tape in place. So it's left for 48 hours, and after 48 hours the patches are removed. You can see the impressions of the aluminum chamber. There is mild redness also. So we have to wait for about half an hour to take the first reading. The area is marked with marking pen, and when we take the reading, always start from number 1 and then go downwards. Use a torch light, look at the patches. If you are seeing any erythema, always palpate the area, because palpable erythema is 1+, just presence of erythema is a doubtful reaction. You can also use junction violet to mark the area. So the patches, the area is being marked with the marker pen. So you can see that there are 26 allergens. We also add, if we are suspecting Parthenium as a cause for dermatitis, we add Parthenium also. So exposure time is 48 hours, and the typical regime is first day apply the patches, third day remove the patches, mark the areas, wait for half an hour, take the 48 hours reading. Second reading is taken at 72 hours. Day 5 and day 7 readings are advisable when we suspect allergic contact dermatitis or when we are using topical steroids in the patches. The reading is done as per the International Contact Dermatitis Research Group. 1+ is palpable erythema, 2+ is papules and vesicles, 3+ is confluent vesicles, and this is irritant reaction. So here you can see 1+ reaction to nickel sulfate and potassium dichromate, 2+ to neomycin, 2+ reaction to nitrofurazone, and this is severe 3+ reaction to PPD. There is confluent vesicle to form a blister. Now how do we differentiate allergic reaction from irritant reaction? Allergic reactions usually show erythema. It is palpable, that means it's infiltrated. We may get papules, vesicles. It usually extends beyond the area of application. Patient may complain of itching, and it classically shows crescendo reaction, that is, it peaks at 72 and 96 hours. Whereas in irritant reaction, there is no infiltration, no itching. We may just see redness limited to the area of application, and it classically shows decrescendo reaction, decreases after 48 hours. Now coming to relevance, which is very important, can be of 3 types: possible, probable, and certain. To give an example, this patient presented to us with dermatitis over the wrist. We suspected allergy to the wrist watch strap. So he was patch tested. He showed 2+ reaction to nickel sulfate. So here the relevance becomes possible. That means he is possibly allergic to the watch strap. So then we did a DMG test, that is dimethyl glyoxamine test, to demonstrate release of nickel from the watch strap, and it was positive. You can see the pink discoloration of the swab tip. Then the relevance becomes probable. So the person is probably allergic to nickel sulfate. And then when he wears a nickel containing material, now here you can see this watch dial, the back part had nickel and it had induced dermatitis, then the relevance becomes certain. Now, what are the causes for false positive reaction? One, presence of excess allergen or increased concentration of the allergen in the patches, presence of contaminants. If the vehicle used is an irritant, normally we use petrolatum. If excess of allergen is applied in the chamber, presence of active dermatitis at distant site or presence of dermatitis over the site of application. Some patients, the reaction due to the microporous tape also can induce false positive reaction, and in patients with angry back syndrome. False negative reaction causes are insufficient concentration of the allergen, insufficient amount applied in the patches, inappropriate vehicle, if readings are taken too early, if the patches are not applied properly, so it's very important to see that we apply the patches properly. Patches applied at wrong sites, and if the patient is on immunosuppressive drugs. Thank you. This is the contact dermatitis awareness ribbon, which was introduced by the Eczema Contact Dermatitis Patch Test Alliance Facebook group in 2016. And this is a very good website. It's called as dermatitisacademy.com, where we can use it to refer or to get resources of all the allergens, where the allergens are present, how to avoid the allergens. So everything is given in this website, dermatitisacademy.com. Thank you very much.
Thank you, Satish sir. Patch testing is a gold standard in contact dermatitis. So knowing know-how of patch test is very important. Now, next is our panel discussion. I call upon Dr. Harsh Tayalyani, the moderator of this panel discussion. Dr. Harsh is practicing in Mumbai. He is a gold medalist. His areas of interest are laser, conventional. Over to you, Harsh.
Yeah, thank you for the introduction. So moving on to the last session for the day, that is panel discussion on contact dermatitis. I would, without wasting any time, like to invite the panelists. We have Dr. Satish Pai from Mangalore, Dr. Vijay Zawar, Dr. Vikrant Saoji, and Dr. Prabhakar Sangoli. No. So we all know contact dermatitis has a very vast clinical spectrum, and it's a very frustrating and sometimes challenging condition to manage, because to try to find the causal association between the offending allergen and the disease is not very easy. So we see lesions ranging from obvious vesicles, edema to sometimes mild and subtle changes. So do you diagnose just contact dermatitis, or clinically do you like to differentiate between allergic contact dermatitis and irritant contact dermatitis, and how does that impact the counseling or treatment of the patient?
Yeah, we usually diagnose as contact dermatitis unless we find that the patient is allergic to certain allergens, then we label them as allergic contact dermatitis. But clinically, I think sometimes it's very difficult to differentiate between ACD and ICD. the clinical picture can look almost similar.
I think history can at times be contributory. Most of the time, what we see commonly use irritant and patient develop reaction. So history is most of the time suggestive. And in irritant dermatitis, the damage is mostly on the epidermal side, outside. So whenever you see like more of a peeling of the skin or necrosis of the skin, likely to be irritant dermatitis than allergic. But I agree, many times it may not be possible, and clinically we just say it's a contact dermatitis.
And usually the onset is fast in ICD, whereas it's little slower in ACD, and mostly they will have burning sensation in ICD, itching will be more in ACD.
So only problem is acute on chronic cases. In acute on chronic ACD, it will mimic the ICD.
So they've already discussed the clinical signs, and history taking is also of utmost importance for these cases. So like they've already said, you cannot always accurately differentiate, though there are some signs that may help you pick up. Now again, we already had a masterclass on atopic dermatitis where they discussed that there are atypical presentations where you have, especially sometimes in adults only, atopic eyelid eczema or cheilitis or hand eczema. So such cases, just based on the history of atopy and recurrent and relapsing rash, would you jump onto the diagnosis of atopic dermatitis? Or sometimes we know there are certain allergens which will cause a distant reaction, say on the lips or eyelid, it could be nail cosmetics. So would you rule out contact dermatitis first, or would you like to label such patients as atopic dermatitis clinically?
So it starts as atopic dermatitis, irritant contact dermatitis, and allergic contact dermatitis. That is a sequence. So for example, this lady, she must have applied some nail polish. It could be ectopic contact dermatitis, also looking at the picture.
Atopic dermatitis predisposes to more allergens.
Now again, we'll move on to the clinical cases. We've seen a spurt in such cases during the pandemic. If you look at these pictures, instead of seeing obvious crusting edema, you see subtle changes where sometimes there are more lesions on the dominant hand and there'll be some fissuring or hyperkeratosis in the web spaces. And we've seen a good number of such cases since the pandemic has started. So what would you like to diagnose these patients as?
Yeah, it's probably irritant contact dermatitis because the lesions are seen on the dorsum of the hand. Common sites are dorsum, web space, and the tips of the fingers. So because of probably use of sanitizer, frequent washing of the hands with cleansers could be the cause.
So cumulative irritant or wear and tear dermatitis. And what kind of advice and education would you impart to such patients, especially in the initial part of the pandemic? People were brainwashed into believing that contact spread of COVID was one of the modes of transmission and not just airborne. So how would you treat these patients and what kind of advice would you give them?
Treatment to use moisturizers as frequently as possible and avoid, if they are using liquid detergents to wash their hands, to use a gel based. Now in our hospital, our pharmacy wing, they prepare a perfume, non-perfume, gel-based and this detergent liquid, which can be used, which reduces the allergic or the irritant potential.
Even during the pandemic, at least in big cities, in many apartments and buildings, maids were not allowed to enter. So most of these people ended up doing a lot of housework also. So any particular advice in case, say for example, women get this more commonly, if they have to work at home and do the household work, what kind of protection should they follow?
I think whenever they require frequent washing, I advise, if possible, like in medical field, you can use gloves wherever it is possible. But otherwise, I used to tell them, wherever you keep a bottle of sanitizer, keep a bottle of moisturizer besides it. So at least they will be using it frequently. I think yes, using a frequent moisturizer is the only solution probably for this.
So,
and another advice is, during pandemic, early pandemic, what I have observed, patient used to fortify the sanitizer along with the strong other irritants like Savlon, Dettol and other things. So that added to the more of insult.
Also, they should wear cotton gloves before wearing a rubber glove, because otherwise the sweat will worsen because permeation can take place with detergents and cleansers.
So wearing gloves and frequent use of moisturizers, and women in fact when they are working in the kitchen, if they are hesitant to use moisturizers, you can just ask them to apply some cooking oil or ghee on the hands also, which also works like a moisturizer. For such patients, would you ask for any investigations or tests?
Yeah, cumulative insult, I don't think we need any investigation.
Unless I find that there is underlying tinea manum or something like that.
Yeah.
Candidiasis is one more complication of frequent.
So we've already discussed the choice of cleansers and sanitizers, and sanitizers also, there was some literature to state that probably ethyl alcohol based sanitizers were little better than isopropyl alcohol, and barrier creams or moisturizers or gloves have a very protective role in this. Have any of you all also come across patients who during the pandemic had probably developed obsessive compulsive disorders to use sanitizers or due to frequent hand washing, and did you manage, were counselors ever had to be involved at any stage?
I think it wasn't that bad, but I think yes, everyone was so
Panic.
concerned. Yes.
Yes.
And there are a lot of 20 seconds you have to keep. So there are a lot of.
So a lot of videos were.
Yes.
Especially, in fact, I have witnessed more of the medical and paramedical professional with OCD than the common public.
Compulsive hand washing. Compulsive hand washing.
Now, this is the second case. I'll just give you a short history. This was a 32-year-old mason who was a mason by profession, and he had history of these chronic recurrent lesions, and he just gave the history that whenever he had off time, whenever he would head back to the village, the lesions would spontaneously improve, and when he resumed work, they would worsen. So there was involvement of the feet, hands, and other than extremities, some lesions here and there even on the trunk. So clinically, when you get such a history, you suspect contact dermatitis to cement. So generally, is this seen as a allergic contact dermatitis or irritant contact dermatitis?
Yeah, commonly I think it's ACD, allergic contact dermatitis, but sometimes wet cement also can cause irritation. So it's more of allergic with superadded irritant contact. Yeah.
So the message over here.
Yes.
Because of formation of slaked lime and the silica, that will cause a lot of chafing. Then it leads to ACD, as sir mentioned. Not only that, even dust can produce airborne contact dermatitis also. That we should look out for.
And it's typically very chronic. I mean, it's
really
for pretty long time.
Very difficult to.
Yeah.
So this was an overt case where on the history and on examination, when you see eczematous lesions, it is not very difficult to suspect what is the offending agent. So would you still patch test such a case where it's obvious overt dermatitis because of chromate or cement?
I think we should patch test because most of our patients, when we tell them you're allergic to cement, they don't agree with us.
Yes.
So we do the patch test, demonstrate that they are allergic to chromate and even cobalt. Yeah, potassium dichromate. And then we tell them, you're allergic, so you have to protect your hand from cement. Changing of occupation, sometimes it's difficult because they are masons. They can't change the occupation.
Though the diagnosis is very clear clinically, but if you do patch testing and show them pictures, let's see you are reacting to this, serves well in future. Like.
Then what kind of treatment will you give to such a patient? Like you already said, counseling the patient and trying to make them realize sometimes is a challenge that the profession that they've been carrying out since so long is responsible for the rash. So what kind of treatment would you give to such a patient?
I think usual line of treatment. I think just before the pandemic, we had examined about 400 construction workers, and we found that cement dermatitis actually had come down because they were using those polyvinyl gloves. So protective measures were taken care of. So protection is most important. And one more thing, my guru, Dr. C.R. Srinivas, used to always tell his patients to use lemon. Squeeze one lemon in a bucket of water. Just wash the hands and feet before going for work. Lemon acts as a reducing agent and probably it converts the hexavalent to trivalent. We don't know, but the incidence of dermatitis used to come down. I think most of them, I advise them to apply a lot of oil because most of them are very poor people. They can't afford your costly barrier creams and this. So I put a lot of oil before going to work. whenever they come back, they should take immediate bath. So at least try to minimize the exposure of semen. That is what you, because changing profession is very difficult most of the time. So by wearing gloves, by wearing this moisturizers, this rubber boots, I think that does help.
Goggles also.
I agree with Vikrant. Only sometimes in early stages of my counseling, I ask the patient how much the patient is involved into this profession. If he is accidentally involved just as a casual stray worker and he is able to change the profession, that serves well. You have to do counseling. If patient is well established in the profession, then the further thing, as Vikrant and sir said, it is difficult.
So at least for chromate or sometimes even for parthenium, when you see extensive lesions, and if the patient, like you said, changing the profession is not easy, would you still consider giving suppressive therapy with systemic agents when the rash is very extensive for prolonged periods of time?
Yes, I think sometimes it's really very disturbing and you need to treat it maybe with steroid, maybe with immunosuppressant. Yes, I think sometimes for extensive lesion, yes.
And counseling for prevention.
Yeah, we can even use phototherapy, narrowband phototherapy to cause hardening of the skin. And just like for parthenium dermatitis, we can use azathioprine also as an immunosuppressant.
So if we have to, stress upon the patient that avoidance is the key. Avoidance of exposure to the antigen is the key. Otherwise, any systemic therapy is not a replacement for avoidance.
So the precautions you already discussed, but at least what I have experienced is most of these patients, their employees are not willing to spend a lot on their gloves, and they've told me, say for example, if someone is doing the flooring, they have to use their fingers and feel what is the final work that they are finishing, the finishing of the work. So many times they said it's very impractical for them to wear gloves and work. And also if they spend out of their pocket the vinyl gloves sometimes, because they do work where there is a lot of rough work included, they do not last long. So this is sometimes very challenging where managing this is difficult.
I often quote my guru, Bajaj sir, when patient tells me, डॉक्टर साहब वो आप ग्लोव्स पहनने को बोलते हैं लेकिन वो उससे नहीं ठीक से नहीं जमता है वो. Then I keep on telling them, see, one of my friends is a heart surgeon. He can do minute heart surgery by wearing gloves. Why you can't? और वो काफी बार उनको अपील हो जाता है.
Yes. So also for such patients, vocational rehab is difficult because that's the only skill that they have in life. So this is also a very big challenge. And sir has already discussed, at least in European Union, some guidelines were enforced regarding addition of reducing substances like ferrous sulfate, tin sulfate in chromium containing products that reduces their sensitizing potential at least. So the incidence over there has gone down, but in our country currently there are no such guidelines available.
But hexavalent cement is available off late, I think so.
What he said is hexavalent should be converted to trivalent. Even though hexavalent is less sensitizing, is more penetrating. Whereas trivalent is more sensitizing, less penetrating. So make it less penetrable.
It's insoluble. Trivalent is insoluble. Yeah. Hexavalent is soluble.
Yes. Now again, this is one case which is fairly commonly seen in clinical practice where you see people have to hide the grays on the hair and they use color, and they may have used hair color for years and suddenly they develop sometimes such extreme reaction also where you see so much edema that it disfigures the face completely. So again, this is a very overt case where you don't need to do patch testing to prove the diagnosis. All clinicians are aware that this is allergy to paraphenylene diamine. So first thing is, how will you treat such a patient who has such an extensive rash, and what kind of counseling will you do for the patient? Most of them will not be willing to...
Because it looks more like a type 1 hypersensitivity rather than type 4 hypersensitivity. So it should be treated like an angioedema. Looking at the patient, there is a lot of swelling. Or was there any oozing and crusting was there on the scalp?
Yes.
So it looks like a more of combined. Definitely she might need a short course of oral steroids and topical steroid lotions, and at least avoid the PPD for at least 3 months so that the sensitization level comes down. So that then we can plan counseling later.
I think the reaction is usually so severe that there is no option but you have to use steroid.
Yes.
Yeah. The edema periorbital is so severe that I think short course of steroid is must.
Agree.
So the next question after you treat the patient is, suppose it's a patient who's in their 40s, 50s and they are not willing to accept gray hair. Can other permanent hair dyes be used by the patient with sensitivity to PPD?
You can still cross-react. I mean, there are a good number of patients who will have toluidine and paraphenyldiamine. I think there are a good number of patients who will cross-react. But whenever I tell them, whenever you want to try anything new, try open patch test first.
So there are other permanent hair dyes available, like sir mentioned, that contain toluidine 2,5-diamine, but at least 50% patients will cross-react. So if you use a substitute also, you have to first try on a small area before you decide.
There are patients whom I have advised henna or indigo based hair dyes, but still sometimes the color shade is not acceptable to the patient, or sometimes they can also cross react.
No dye without PPD will be as dark as the dye with PPD. So they have to accept that it is going to be less darker shade. Some people are not ready to accept. I know of a patient who was a general manager. He told me, sir, I will take 3 days of steroid, but I can't live without a hair dye. So I think every time he told me that 3 times he has taken steroid. I don't know whether he could
learn on their own.
Yeah.
Even if they go to the doctor, he prescribes a short course of steroid. They keep on taking on their own.
I think if the PPD is there, then PED is there, as you mentioned, and TDS is there, which is present in cuticular. So that can be tried. They are all permanent. Unfortunately, these vegetable-based dyes are semi-permanent.
Yes. So
Vegetal.
there is cross-reactivity, so it is better to test. So again, patch testing in such an overt case, would you still do, or do you need to prove to the patient this is hair dye allergy, or most of them understand the causal relationship on their own?
We do in our department, but you can do, as Dr. Vikrant said, that you can do open test and see.
Yes.
So actually, PPD could be negative because it's incompletely oxidized PPD products. They are allergenic. So test the actual hair dye what the patient is using. No, that will be more appropriate.
So
toluidine based are another allergens along with PPDs.
So for such a case, if you all do a small patch test, you could use the patient's product, you could use PPD instead of doing the standard series, you could use a toluene 2,5-diamine based product, and some herbal dyes also will have some amount of PPD. So if you're trying to find a substitute for the patient, you can do a very small patch test with 4 or 5 things, and that way I think you will be able to determine whether some hair color can be used safely or not. And for people who are reacting to both the permanent hair dyes, sir already said there are some henna based or herbal based products, but they do not penetrate the cortex, so they are not permanent hair dyes, and generally their patients are not satisfied with such products. If such a patient wants to get a permanent tattoo done also, what would you advise? Or in counseling, I think one more important part is they should avoid temporary henna based tattoos, because that has the highest concentration of PPD. But if such a patient comes to you and asks you, should a permanent tattoo be done, would you be worried about it, or?
You have to access the right situation which we are going to take.
Tattoo also has got its own disadvantages.
So
I think permanent tattoo do not have PPD. There's only the temporary tattoo.
So again, it's not a regulated industry, but most of the permanent tattoos are metallic inks. You can use, but it is better to patch test what they are using, because they've cross-reacted, because along with the metallic inks, they may have some azo dyes also, and PPD is known to cross-react with azo dyes.
Yes, Dr. Bose, you wanted to say something. Yes.
Can I make a point?
Yes, sir.
Black henna tattoo, especially for the tattoo, if they say one already beginning for 1 year, those people tend to have allergy with black henna tattoo. It's always advisable not to do black henna tattoo.
No. Black henna tattoo, we said, is to be avoided. I was asking about permanent tattoos that a tattoo artist does.
Black henna tattoo because you don't know what is the ingredient over there, it can cross react.
So now again, such kinds of cases, at least in our country, are fairly common, where you see people with such slate grey pigmentation mainly on the face and neck, and you call it Reals melanosis, pigmented contact dermatitis, or lichen planus pigmentosus, ashy dermatosis. So there is some literature where this has been associated with a type of contact dermatitis, also pigmented contact dermatitis. So can you diagnose this condition clinically, and do you believe it's a separate clinical entity, or all these are same eggs in a different basket?
I think it could be, I consider them more or less spectrum of the same thing.
Cumulative insult. It's a pigmented cumulative insult.
It's called acquired dermal macular hyperpigmentation. Pigmented cosmetic dermatitis, usually it involves the hair margins, preauricular areas, cheeks, little bit of scaling will be there. That gives a clue that it could be a case of pigmented contact dermatitis.
So patch testing or repeated open application tests in such a case too?
ROT is better in this,
Yeah. I think repeated open application test would be useful.
Again, common allergens associated over here are fragrances, cosmetics, and even PPD, which is responsible for such a rash. And henna, yes. And unlike the other types of contact dermatitis where you can treat the patients very quickly, what is the kind of advice that you would give to the patient over here?
For pigmented, maybe topical immunomodulators, and then sunscreen, and then for pigment to take care of pigmentation.
So role of photoprotection.
I don't do patch testing, but I tell them not to avoid hair dye, and as far as possible, they should avoid the cosmetics to minimum they can use that, like calamine lotion or something.
Patch testing for such kind of patients often turns out to be negative. It is not easy to get a positivity in such patients, even if you consider a collective insult of PPD or PPD based other agents.
And again, this is one very common scenario. It's the most commonly reported contact sensitizer in the world, nickel, and you may see different morphologies of such a rash, and we see patients quite often. But along with this, if you go through literature, you will also find that nickel is so ubiquitous. It is there in food, it is there in any metal item that you use. So, and sometimes you go through where patients also use topical diclofenac. So would you suspect systemic contact dermatitis due to nickel in cases, or have you actually come across such cases, or it's only in literature that you've read? Or your opinion on systemic contact dermatitis?
Systemic contact we have seen with medications, which is called as symmetrical drug reaction. Yeah, but metal causing like nickel or cobalt, I think when they take cyanocobalamin they can develop. It's only in theory, but I have not seen.
I will like to share two cases. One patient who was sensitive to nickel. She sustained some injury, fracture, followed by steel implant, and then she suddenly started getting large blisters. Almost every dermatologist she has seen has put a diagnosis of bullous pemphigoid, advanced biopsy, immunofluorescence, everything. Immunofluorescence and serology turned out to be negative. Bullous pemphigoid was suspected even on histology. But then main problem with this patient was, the systemic nickel reactions. And once that was taken out, 2 years suffering of the patient suddenly dramatically gone down. This is one patient. Another patient of palmoplantar psoriasis, he suddenly developed pustular reactions. Kept on getting these pustular reactions off and on. I don't know what was the source of systemic nickel, but I read somewhere in the literature about the low nickel diet and everything. I gave it to the patient, asked him if he can follow and do some counseling. And then suddenly one fine day patient said, Doctor, what you were saying is right. After I changed my dieting schedule and reduced this nickel containing food, this dermatitis is not requiring now the topical medication which I used to apply off and on. I mean, these are stray cases, but just to share with you.
I think Bajaj sir once says it may not be as rare as we think. Probably we are missing those cases.
Any contact dermatitis which worsens suddenly, or it becomes disseminated and it becomes treatment resistant, then we have to suspect systemic contact dermatitis.
Now again, suspicion of the offending allergen can be quite a task, and out of the box thinking is needed. This was one case which I found, which has been published by Dr. Zawar only. Sir, how did you prove the diagnosis over here?
This was actually a interesting case which taught me a lot. This was a person who used to get recurrent finger dermatitis, and I could only suspect that this is contact dermatitis or something, but I was not able to pinpoint. After few repeated episodes of this type, intermittently this dermatitis used to settle, it used to exacerbate, and then I was not very sure, but then I started taking history like a medical student, and then I found out his occupation is a priest. So I asked him, what are those things what are you must be handling? And then gradually I realized that the time of exacerbation is around the time of his rituals of Sankashti Chaturthi and all this, So he came out with the history of hibiscus plant handling. He used to do all those mantras of Chaturthi. So this was an exotic case that made me learn, and I labeled this as a Chaturthi finger. So, and the editor of Contact Dermatitis, the #1 European journal in field of contact dermatitis, he liked this caption, but he wanted more knowledge about this Chaturthi and these rituals. So I had to do a lot of correspondence with him, and he liked the idea so much that he put this on the cover page of that issue.
So
thank you, sir.
Take home message over here is sometimes multiple visits are needed, and history taking you have to also give importance to the profession of the patient, hobbies of the patient, and whatever they are handling. One just last slide where we'll do a quick fire on patch testing. So sir is from an institute where patch testing happens. I would like to ask the panelists who are also into a private setup, do you patch test? And the systems and protocols sir has discussed, but how practical or cumbersome do you find patch testing? I believe it's a very underutilized tool in dermatology at
I
least.
think I got the kit. I did it. I tried it for a few cases of ABCD. Did work. Then sometime I tried because most of my patients are from outstation. It's very difficult to ask the patient to come back again. So what I did, I applied the patch and asked them to remove it and take a photograph and send on WhatsApp. So that did work in few patients. But then I realized the quality of photo was not good. It was not proper. So somehow I stopped it. But I think that may be a solution nowadays.
I used to do this during pandemics.
But I think, yes, I mean, if you are in institute, it should be, I mean, it's very helpful thing. I think I'm attached to medical college where we have now introduced this.
So sir rightly said, sometimes ensuring compliance of the patient for 96 hours and delayed reaction readings also, which are known to happen sometimes at 7 weeks, is difficult. You can make use of telemedicine. And again sir, do you believe in using standard series or focused patch testing as per case and histories?
I think initial screening standard series is better, unless we see lichenoid reaction in the oral mucus, then we can do with dental series, or for varicose ulcer we can do with the preservative series.
So sir, you also mentioned that you use the chemotechnique kits which cost more than $1,000 and they have a very short
Indian standard series
from chemotech.
From chemotech. It doesn't cost $1,000. It's little bit expensive than our cystopic one, but it's not very expensive.
How often do you replace the kits and how do you
Once
store
in
them?
2 years.
Once
I
in
think
2 years.
expiry is for 2 years. Yeah, quite short. 2 years. Chemotechnic is 2 years. It's 5 ml syringe, so you can use in many patients.
But you can use stable antigens little over longer time.
Yeah. I'm coming to that.
There was a publication also.
Exactly.
They have tried with the
From PGH Chandigarh.
expired date, yes,
Expired
this and it
date.
worked, yeah.
Yes. So, and again, is it viable and practical, do you feel, to include patch testing in non-institute based practice? Because I feel okay.
No, in fact, if you have a manpower and if you have time, so what I realize, when you are busy, it is difficult for you to, plan a patch test. It requires certain time. So I generally give them a patch test appointment only at a different time. So that has worked with me. I don't know what about Vikrant.
No, I tried with few patients, but I think somehow it has not become, I mean, it's become difficult to, practical difficulty with a lot of practical difficulty.
I sent it to one more center where they have got a contact dermatitis clinic. They do.
So that is also one solution where, like how sometimes you have to refer for phototherapy. If there is someone who focuses on contact dermatitis, you could refer to them. So your experience on photo patch testing also, because your institute also does the
Not very useful. I think 3-4 years ago we had done. So it didn't help us much. So,
and just the last slide. So Allergen of the Year is actually awarded by the American Contact Dermatitis Society since the year 2000. It is announced to draw attention to underdetermined common allergens, and in 2022 they announced aluminum as the allergen of the year. It is used in most of the fin chamber patch test systems that we use, and in 2021 it was acetophenone azine, which is used in sporting wear in protective shin guards. It's a foam based product. So do you feel, at least in our country, we need to be aware of newer allergens that are relevant and that will help us manage our
Aluminum is used in all vaccines.
vaccines also? Yes.
So COVID related rashes.
Yeah, so they can be sensitized after the vaccine.
In fact, Professor A.K. Bajaj sir, before his demise, he presented on paper where he had developed, identified new allergens like yang yang oil in so many of our Indian, he reported newer antigens in India.
Yes. So just once
Regarding newer antigens, no, I read about methyl isocyanate, and then after reading reports of this allergen, in fact, I started catching more patients of contact dermatitis, though I couldn't test them because it is not there in the standard series.
So we saw the traditional fin chambers. Nowadays there are chambers available which are made with elastic and waterproof dressings also, which are IQ Ultimate chambers, which are by chemotechnique only. So you can allow the patient to exercise and take a shower, and this will probably make it a little more practical, because most patients, at least in climate like Bombay and most Indian cities, will not agree to not shower for 2 days. They would deny a patch test directly.
No, even regular patch testing, Dr. Kripashankar used to use it. You can put a transport tape at the edge and just put a mark. So patient can have bath.
Yes.
Is doing it, yeah.
So again, they already quoted the study that their expired products have been used, and most allergens maintain 80% of their allergenicity. So you can use the exposed products. Thank you to the panelists and to the audience who are still patient to be here for this neglected subject.
Yes, sir. There are several, right from nickel to cement, there are several.
Tulip fingers.
Tulip fingers,
Tulip
yeah.
fingers.
Onion of.
Onion, mirchi, ginger, I have seen them very common. Henna.
I would like Dr. Kiran Gutse sir to come for felicitation. I would like to invite Dr. Timbadia sir.
No, and the women, you've been working in the kitchen, can use the soapless cleansers. Only when we are traveling, we need that, when water is not available. Otherwise, soap and water should be as good as sanitizers. So avoid completely,
Dr.
rather than
Satish
using
Pai,
like
sir.
which base. Yeah.
Dr. Satish Pai sir. Dr. Vijay Zawar sir. Dr. Vikrant Sauji sir. Dr. Prabhakar Sangoli sir. And Dr. Harsh Thayalini sir.
Very well done.
Thank you. So the last part of the meeting is valedictory, and I would request, before the valedictory, I would request Sandipan Dhar sir, the President of Society of Eczema Studies, to make some announcement. Dr. Sandipan sir. So he's making some announcement.
not many people left, but still I am overjoyed to have this wonderful proposal from Dr. Kiran Godse and Dr. Abhishek Dev, that the journal of cutaneous allergy their proposal is that why can't society, Skin Allergy Society and Society for Eczema Studies jointly take over the journal, and I was very happy to know about that, and I discussed with the executive committee members, and we'll have more discussion. More or less it has been agreed upon. I think this is a very good gesture, and there are several such journals. Just look at the Pediatric Dermatology Journal. It is the official organ of three biggest societies of pediatric dermatology. Society for Pediatric Dermatology, #1 organization of pediatric dermatology in the world, American Society. BSPD, British Society of Pediatric Dermatology. Then ESPD, European Society of Pediatric Dermatology. Three, societies' official organ is Pediatric Dermatology Journal, which is from 1982. So if this can happen globally, why we cannot create such, instance in India? Why we cannot collaborate, join hands together for the betterment of the science, for the betterment of the subject, for the contribution to, giving more opportunities to the younger generation to write, and for, ultimate goal is the upliftment of our allergic societies together at the international forum. I sincerely thank Dr. Kiran Godse and Dr. Abhishek, the entire team of
So quickly, as a part of validatory, I wanted to announce the results of the skin allergy quiz, national quiz that we conducted. So can we have the slide of the winners? So the first winner of the skin allergy quiz, which was conducted on the 1st of October, is Dr. Vignesh Narayan from Postgraduate Institute of Medical Education and Research, Chandigarh. The second winner is Dr. Ashika Doshi from BJ Medical College and Civil Hospital, Ahmedabad. And the third winner is Dr. Benazir Hakim from Neil Ratan Sirkar Medical College, Kolkata. I would also be happy to announce the results of the today's oral paper presentations, and the first prize goes to Dr. Sushil Singh from Kolkata Medical College. May I request Dr. Kiran sir to hand over the certificate to Sushil. The second prize goes to Dr. Meghna Singh from Dr. D.Y. Patil Medical College, Navi Mumbai. So while the felicitation is going on, I would like to take opportunity to give vote of thanks. From the Skin Allergy Research Society, we are happy to thank and appreciate the efforts of all chairpersons, all moderators, and the speaker, Dr. Luis, all the way coming from Brazil, and also Dr. Anna for accompanying him and staying with us for 2 days. I'll also thank all the speakers from all 4 parts of India. I'll thank IIDVL Mumbai branch for associating with us for giving 2 credit points. I thank MMC Observer and all delegates. And lastly, I will also thank IPCA for helping us in conducting this successful meeting. Lastly, I would request Mr. Vishal Arora sir from IPCA, Vice President, to give vote of thanks. Thank you.
Good afternoon, everybody. On behalf of IPCA, I take this opportunity, first of all, to congratulate Dr. Kiran Godse for such a successful meeting and for conducting such a wonderful session. I will take this opportunity to thank the entire Skin Allergy Society team, Dr. Kiran Godse, Dr. Abhishek Dev, for giving us this opportunity to IPCA for getting associated for this wonderful forum. It had been one of those meetings where we also really equally enjoyed the entire program. I will take this opportunity also to thank our international speaker, Dr. Luis and Dr. Anna, for traveling all the way from Brazil to this place and enlightening us in the field of urticaria. Wonderful session, sir. We have been really enlightened with your presence. I will also take this opportunity to thank all our faculties and the panelists who had been there on the dais and have contributed immensely to the entire session and have really helped the session to move to the next level. I'll also take this opportunity to thank all our delegates who have traveled from all across India, and especially our Mumbai delegates who have traveled all across and have made this program a big success, because without their presence, the program would have not been successful. Because when I've been talking to everybody, and everybody had really appreciated the program well. So thank you very much. On behalf of IFCA, we are really grateful to be associated with Skin Allergy Society. Thank you very much, sir. Thanks a lot.